This conference will now be recorded.
Well, since I hope everyone is here and we have a lot to cover, so we really should begin today's webinar. I really appreciate you all for attending today. A very good morning, afternoon, or evening to one and all present here virtually with me today. Let me introduce myself. My name is Jessica, Conference Secretariat at Coalesce Research Group LLC, and I will be available for any of your queries or questions throughout the webinar to help you out technically and organize this webinar successfully. For the next 5 minutes, please allow me to give a brief description about our organization, Coalesce Research Group, and also for further instructions. Coalesce Research Group LLC is very delighted to welcome you all the participants, speakers, supporting associations, students, delegates present virtually with us today. With the aim mark the scientific excellence by facilitation conversations, sharing knowledge, College Research Group follows through the objective of setting standards in delivering excellence in the research among the researchers, academicians, and industries, promulgating the research through conducting events and online webinars from various fields of science, especially from the stream of medicine, science, engineering, and technology. Within a short duration, we have succeeded in creating a platform for developing a strong professional network with the people across the world from their respective fields that they haven't connected in a while. As a global scientific event organizer, we plan and carry out international conferences, meetings, seminars, symposium, and workshops providing the best delegate experience, excellent networking opportunities, conversations leading to innovations, learning new opportunities, lasting working relationships, and professionalization with the professionals around the global network. Just recently, we have also started our own platform for open access peer reviewed scholarly literature, where all the content is freely available without any charge to the reader. We aim to share the new recent advances through scientific publications, which will help in minimizing the borders and contributing the use of research works of eminent authors, scientists, research scholars, students, etc., across a broad spectrum of medical, clinical, pharma, and engineering scientific disciplines, and its subspecialties to promote the ideas which will guide the development and facilitate the use of scientific information and ensure its quality, and also will be the connecting link between researchers and scientific community. We are committed in ensuring that our journals are disseminated worldwide so that the researchers are able to access their content wherever and then whenever they need it. As being a very few new journals, we have coined up some interesting one, and we have also formed the editorial board, and will be very glad if any of our today's attendees, speakers, students, and delegates could extend their support by checking the journal and will be interested in publishing in an inaugural issue at any of the journals according to your area of expertise. Finally, I would like to thank all the attendees and participants of today's webinar and hope you will enjoy this and gain some knowledge from the sessions today. We also hope your participation will contribute to new research findings that will lead to new collaborations and research initiatives. Before we start with the sessions, I guess some of you will be new to GoToMeetings app. Let me just explain you the important tools required for the presentation. On the GoToMeetings app or web page, you can find four icons at the bottom of the center of your screen. That is mic, camera, share, and leave. Mic, click on that to mute or unmute yourself. I request you all to stay muted while our speakers are presenting their research work so that it doesn't cause any disturbance to them. Camera, this you can use this button to share or unshare the webcam. If you have the option to share the webcam, you can do it, or it is completely your choice. Share, you can use this button to share your screen. This is your main part during your presentation. After I call your name from my side, I will be making you the presenter, and only when I give the permission you will be able to share your screen. So once I make you the presenter, you can click on the share button and you will find a pop-up window to share your screen. Then you can able to share your presentation with us, and the speakers using the MacBook, they have to give the permission in system preferences. Then you have to log out from the session, again you have to log in, then you can able to share your screen with us. Last one is the leave icon, where you can use this to leave the session. On the top center, you can use the options to change your display settings. At the top right corner, you will have three icons: people, chat, and settings. In the chat option, you can chat with me or any other participants. For the settings, you can use this button to check for the settings of your speaker and microphone. So, as mentioned, kindly remain muted during the presentation so that our presenters don't get disturbed. And for any questions, you can ask the questions or you can send your questions in the message box. Well, let's not take much of your time. Finally, I would like to request you all to please give a brief introduction about yourself before starting with the session so that we can know about you virtually. Now, let's move into our sessions. Our first session is presented by Dr. Adel Ecledius from University of Western Australia from Australia, and the title of the talk is Can Nurses Stop Unexpected Death in the Ward? Dr. Adel, yes, you are the presenter now. Can you please unmute yourself?
Yes,
Now it is audible, and now you have to click on the share button.
sure.
Yes, we can able to see your screen. You can make it a full screen. Perfect. Please start continue.
Good morning in Dubai. My name is Adel Ecladius. I am an associate professor of medicine in University of Western Australia and a senior staff physician in Royal Hobart Hospital, Tasmania, Australia. I have with me my registrar, Betty, uh, and the reason for this that I got admitted to the hospital to have a surgery tomorrow and I'm taking a prep. So I got Betty beside me as standby if I need to leave the session for a slide or two. So Betty will continue with the same slide. So uh, I have nothing to disclose and no conflict of interest. And the first slide will be presentation of one of my patients who really changed my practice. This is a 72-year-old man admitted on the 17th of June in 2019 with generalized seizure for 45 minutes and acute confusion. This was in a regional hospital in Western Australia. This patient was unwell for 3 days before admission in the form of nausea and headache, but there was no systemic symptoms or fever, and he was not diagnosed with seizure before. The past medical history was notable for carcinoma of the prostate with metastasis, and patient was treated with chemotherapy and radiotherapy, who also had been diagnosed as chronic kidney injury for some time, and he needs some medication to support his anemia. He also had history of high blood pressure but does not require any medication. On examination, his blood pressure was elevated at 240 over 150. His heart rate was 150. Patient was very agitated and detailed neurological examination could not be performed. Initial blood investigation showed that this patient has metabolic acidosis as his pH was 7.1, his lactate was elevated, his bicarb was decreased, his white cell count and the platelets were elevated, his inflammatory markers were normal, and the kidney function was at the baseline. He had an urgent CT brain which did not show any acute pathology, i.e., no hemorrhage. Bedside echocardiogram did not show any sign of heart attack or dissection of the vessels. His delirium and confusion was not responsive to midazolam, and he required admission to ICU. He was mechanically ventilated and intubated. Patient observed in the ICU improved spontaneously, and he was extubated and transferred back to the medical ward on the 19th of 6, 2019. He has some investigation, including blood tests for vasculitis and autoimmunity. He had a thyroid function test which showed detection of antibody, which did not show any detection of antibody. He has some specific investigation for encephalitis, which was negative, and he has a metabolic panel, which was within normal range. He required CT-guided lumbar puncture, which showed elevated protein. His CSF was sent for bacterial and viral study, and because the diagnosis had not been made in view of the confusion, this patient was treated empirically as bacterial and viral encephalitis. He was started on IV ceftriaxone and acyclovir. Quetiapine and olanzapine had been commenced for ongoing agitation. No further seizure happened, and due to ongoing confusion, he was transferred to a large tertiary hospital in Western Australia under the neurology service to have an EEG monitoring and further investigation. MRI of the brain confirmed that he had right mesial temporal sclerosis, which confirmed the cause of the seizure. EEG did not show any more epileptiform activity. Medication including olanzapine had been seized and quetiapine had been reduced. Confusion started to improve. Patient was given a diagnosis of temporal lobe epilepsy, was post-ictal confusion, and the arrangement had been made that this patient should be started on small dose of carbamazepine and to be followed on the neurology seizure clinic, and this patient should be discharged back to the home hospital again in Western Australia. And while this patient was waiting on the discharge lounge to be discharged back to our hospital, and his family was waiting for him, this patient sustained a cardiac arrest. A code blue was initiated and med call attended, which included the ICU physician, ED consultant, treating physician, and the rest of med call. When med call team attended, GCS was reduced and there is no vocal neurology. While this patient was waiting for urgent CT brain, there was no signs of life, and cardiopulmonary resuscitation as per advanced life support guideline was commenced. This patient transferred to ICU for further resuscitation. His trachea was intubated and he was mechanically ventilated again. And despite the continuous resuscitation for 45 minutes, this patient did not resume any signs of life. And he was deemed dead after 1 hour from continued resuscitation. Family meeting was organized urgently and coroner was contacted for further investigation. So, why did this patient die suddenly and unexpectedly? This patient had suffered from SUDUP. What is SUDUP? SUDUP is a sudden, unexpected death in epilepsy. So, in this next two slides, I will talk briefly on the definition of sudden, unexpected death in epilepsy, what is the incidence, and why it occurs, and what is the management, and why this clinical scenario has altered my usual clinical care. So SUDUP is defined as a sudden, unexpected, witnessed or unwitnessed, non-traumatic and non-drowning death in patient with epilepsy, whether this patient has seizure or not, but should not have a status epilepticus, which is continued seizure more than 30 minutes, and the post-mortem examination should rule out any structural or toxicological cause for the death. Near SUDUP describe cases where patient had SUDUP which could be reversed by resuscitation. Sudden unexpected deaths happen between 2 and 18% of all death in patients with epilepsy, and the incidence estimated to be between 0.2 to 1.1 per 1,000 person in children and up to 1.2 per 1,000 person years in adult with epilepsy. Multiple physiological factors could be contributing to the death after the seizure, which could be cardiac arrhythmia, seizure-induced depression of the brainstem, or neurogenic cardiorespiratory depression, or some patients have genetic factors, especially on the sodium potassium channel ions. Uh, this is a repeat study which showed that patients had increased incidence in generalized tonic-clonic seizure, especially where seizure is not under control. And we mentioned before that genetics played a role, and they found that patients with congenital long QT syndrome also has predisposition to die suddenly uh, in epilepsy. Uh, Many mutations had been discovered which predispose the patient to sudden unexpected death in epilepsy. And this genetic mutation can be detected by investigation and genetic studies. And the findings has been confirmed in many studies. And the common mutation found in SCNA N1A, SCN1B, and SCN2A. And other studies found that children with Dravet syndrome are at risk to develop the sudden unexpected death. And Dravet syndrome is a syndrome characterized by seizure and slow mental delay. And as we mentioned that the sudden unexpected death, unfortunately, is common in epilepsy patients between the age of 18 and 40. It is uncommon in children and very, very uncommon in elderly patients. And in these slides, if you miss most of the talk, this is the most important slides on how to reduce the risk of SUDUP and what is the take-home message and how can nursing staff prevent SUDUP. Identifying high-risk patient is very important. And this high-risk patient, in summary, are patients with uncontrolled generalized seizure. The most important thing which has been agreed in the studies and literatures and supported by the American Academy of Neurology is every patient with a recent diagnosis of epilepsy should have been a disclosure to patient and family and carer about the chance that their loved one have a chance of one or even more than one over 1,000 chance to die suddenly. Why the disclosure is important? The disclosure is of paramount importance because it lessens pain, grief, and blame among family in the event that should does occur. Number two, it eliminates medico-legal issue regarding unexpected death. Number three, it helps the clinician and patient to share the treatment goal and be on the same page. And most importantly, it established truth telling relationship between patients, carers, families, and the clinician. It also avoids false sense of security and allow people with epilepsy to express an anxiety about their diagnosis and encourage transparency and discussion, open discussion. Also allow people to organize their life with a reasonable expectation and allows people with epilepsy and their caregiver to reduce potential risk of SUDOP and reduce risk behavior among patients. What can nursing staff do to prevent death inside hospital and prolong life? This can be done through nocturnal supervision. Avoid prone position for patient admitted with epilepsy because most of the unexpected death happens during night and they found most of the patient on prone position. Number three, using safety pillows. Number four, using seizure alarm. Number five, avoid single bedroom. Monitoring device and remote listening device. Optimum medication care. Patient with difficult epilepsy to treat should be referred to specialized epilepsy center where consideration for surgery in high-risk patient. Regular EEG monitoring because this can disclose seizure even where patients has no convulsion. Avoidance of high precipitating factors like alcohol and antipsychotic medication, and avoidance of medication which can trigger SUDOP in males like phenytoin and carbamazepine, and avoid also triggering SUDOP in females like lametrogene or lamictal. Only nurses can do this by observing patients in single room, providing safety pillows, avoid prone position, and responding to alarm device. Thank you very much for your attention, and I'm going to stop here and invite the floor for any question for me to answer.
Thank you, Dr. Adil, for your presentation. So, anyone having any questions?
I would like to.
Yeah, please continue.
It is not really a question. I just want to say thank you so much for sharing with your life experience. I would definitely talk about it to my nurses as well. And I wish you a good health and a good day tomorrow for your surgery. Thank you so
Thank you
much.
very much. Thanks.
Thank you very much, Dr. Adil, for your presence and presentation. It was really a nice one. So, I think no one have any questions. So, we'll move forward for the next presentation. So, by the next presentation is from Dr. Indy Wang and Rubin Lee from First Affiliated Hospital of Batao Medical College, Inner Mongolia University of Science and Technology, China. And the title of the talk is A Case Report of Hyperemesis Gravidarum Combined with Liver Rupture. Hello, Dr. Indy Wang. Hello, Dr. Wang. Are you active with us?
Yes, yes,
Yes. So you are the presenter. Please click on the share icon on your screen.
okay. Wait a minute.
Okay.
My app.
Yeah. Can I know the issue?
Yes, wait a minute. I need to
Okay.
get it.
Is it a MacBook?
Yes,
Okay, okay. Then you need to give permission in system preferences. You have to log out from the session. Again, you have to log in.
okay, okay. Sorry. The next is me, okay?
Yes.
Uh, I not share my point. I need to step to it.
I'm sorry. Yes, so again I make you the presenter. Now you can click on share, it will work.
Yeah,
Yes, perfect. Now we can see your screen. Yeah, you can
thank you,
make it a full
Professor.
screen.
I'm so sorry. Yes.
Perfect.
Okay. Thank you, Professor. I'm so sorry. My name is Wang Yingdi. I'm from First Affiliated Hospital of Baotou Medical College, Inner Mongolia University of Science and Technology, China. I'm very pleased to be here to join this forum. The topic of my presentation is a case report of Hammer-Ramsey grave diagram combined with liver reparature. My presentation will include these three parts. First, some background information about this case. Second, the case context, and the last, some conclusions we have got. First, as we all know, spontaneous hepatic rupture in pregnancy is a very serious and rare complication of hypertension in pregnancy. It often occurs suddenly after HE-LLP syndrome triggered by preeclampsia and is associated with low mobility and high mortality. The pathophysiology involves vasospasm due to increased concentration and sensitivity of circulating vasopressin during pregnancy. Next, let me present a case I saw in the clinic. The pregnant woman was admitted for 2 days with the main finding of elevated hypertension. She usually had regular menstruation. On the second day of admission, the patient reported abdominal pain and distension, gradually worsening with nausea and vomiting, with painful face. The patient was found to have a large amount the abdominal swelling of the left lobe of the liver with obverse spring, and a 3 to 4 centimeter long fission with active bleeding was seen in the left outer lobe of the liver, near the hepatic round ligament, with extensive tumor. A drainage tube was placed under the left lobe of the liver to close the abdomen sequentially at the end of the operation, and the patient was transferred to the ICU after the operation. The patient's baby girl was sent to the NICU for several resuscitation. In NICU, she had recurrent infections and died of respiratory distress 51 days after birth. The last, spontaneous hepatic rupture in pregnancy poses a significant challenge to clinicians in terms of the birth diagnosis and treatment. Surgical intervention is necessary in women who have had hepatic rupture, and the truth of the surgical approach needs to be fully explored. Laparoscopic hemostasis by electrical regulation and tumor gas picking may present one of the options. That's my reporter. Thank you.
Yeah, thank you, Dr. Indy Wang, for your presentation. So, anyone have any questions? No questions then. Thank you once again for your presence and presentation.
Thank you.
Thank you. So, our next presenter is Dr. Lara Strachan from Campbellville Town Hospital, Australia. And the title of the talk is Toxic Shock Syndrome as a Result of Group A Streptococcus Infection. Hello, Dr. Lara.
Hello?
Yeah, hi. So, you are the presenter now.
Yes.
Please share your screen with us. Yeah, it is visible now, and you can make it a full screen and start presenting.
Um, how can I make it a full screen? Sorry.
Yeah, you can go to slideshow in the top bar. Yeah, there also you can click the last option. No, that,
Yeah.
yes, perfect. Yes, perfect. Yes, continue.
Okay. Hello everyone, and it's good evening from Australia, Sydney. My name is Lara Strakian, and I'm one of obstetric and gynecology registrar from working currently in Australia, Sydney. Um, my presentation will be about toxic shock syndrome secondary to group A streptococcus infection. Before starting my presentation, let me grab this opportunity to hugely thank the Coalesce research group and the second international obstetric and gynecology conferences for such a great conference. And also thank you so much for accepting my case and giving me this opportunity to present this mini lecture on this interesting topic. And also special thanks to my co-author, Dr. Sonal Karia, an obstetrician and gynecologist, and subspecialty in IVF and reproductive endocrinology for her help and guidance throughout this presentation preparation and the case report submission. Thank you, Dr. Karia. Um, we'll start my presentation with the background of the case. So she was 37 years old, para 3 with poor obstetric history. She had one normal delivery at term, complicated with the postpartum hemorrhage, required a blood transfusion and ICU admission. And then followed by that, she had a stillbirth at 22 weeks for cervical insufficiency, and then preterm delivery of 20 pregnancy via cesarean section at 35 weeks. And her last pregnancy was second trimester miscarriage at 19 weeks, despite of elective circulage. She is morbidly obese and a smoker, but no any other remarkable medical history. And in terms of her gynecological history, she has a history of menorrhagia for which she required a hysteroscopy and DNC with ICU admission postoperatively for severe hemorrhage. Otherwise, no any significant gynecological history. The patient presented to emergency department with 2 days history of fever, vomiting, diarrhea, and green vaginal discharge with lower abdominal pain, shortness of breath, and oliguria for 24 hours duration. On examination, she was conscious and alert. She was tachypneic and tachycardic of 124 to 133 beats per minute. She was severely hypotensive with systolic blood pressure of 60 millimeter mercury, and she was clinically dehydrated with cold, clammy peripheries, and the abdomen was acute abdomen. She was admitted to ICU in a view of septic shock, and central venous arterial line was inserted, and she started on vasopressors and intubation. In terms of her blood test, she has high inflammatory markers of white cell count 24 and significantly high CRP of 348. She has significantly high lactate of 12 and features of acute kidney injury of creatinine 407 and low GFR of 11. The coagulation profile shows INR of 1.5. CT abdo-pelvis was unremarkable apart from simple right ovarian cyst, the same as well with the pelvic ultrasound, showing small fibroid with a small right ovarian cyst of a simple in nature of 3 centimeter in size. Chest X-ray shows bilateral infrahilar patch opacities, no pleural effusion, and bedside transthoracic echo shows hyperdynamic heart with no pericardial effusion or pericarditis. She continued to deteriorate despite of aggressive resuscitation, and therefore she underwent an explorative laparotomy. Intraoperatively, she was found to have a congested uterus and surrounding structures, and right ovarian cystectomy was performed. And then by the end of the procedure, there was a profuse pass through the vagina and the anus. Speculum and PR examination both were unremarkable in terms of no any evidence of rectovaginal fistula was found. Postoperatively, there was no any clinical improvement, and she continued to deteriorate to multi-organ failure despite of aggressive IV antibiotic, vasopressors, and dialysis for acute kidney injury. Therefore, she underwent a second laparotomy for suspected for subtotal hysterectomy and bilateral salpingectomy for suspected pelvic infection as a source for her sepsis. The intraoperative findings this time shows necrotic uterus and dried ovary with no any obvious bowel pathology. The bladder was densely adherent and required extensive dissection, and the total expected blood loss intraoperatively was about 2 liters. The histopathology revealed ischemic necrotic and hemorrhagic infarcted uterus, benign leiomyoma and adenomyosis with normal fallopian tubes. The progress of her clinical course postoperatively, the blood culture result came back, and that was indicating group A streptococcus. She was commenced on clindamycin. She was commenced on clindamycin and benzyl penicillin. The intraoperative culture swabs revealed Candida albicans, therefore she was commenced on fluconazole as well. She continued under multidisciplinary care, and she continued on IV antibiotic, vasopressors, steroid, albumin, and dialysis. She developed critical illness myopathy, developed a brief episode of AF, required cardioversion and amiodarone for that. The transthoracic echo, again, there was no evidence of vegetation. On day 5, postoperatively, there was a suspicion of compartment syndrome with bilateral ischemic changes of bilateral lower limbs due to excessive vasopressors, septic shock, and DIC. On day 9, postoperatively, she was extubated, and there was significant improvement in terms of her blood biomarkers for both inflammatory markers, lactate, and the kidney functions. On day 30 postoperatively, she was transferred to a tertiary hospital and had right below knee amputation. This was all about the case presentation. I'm just going to have a brief discussion about the streptococcal infection and the toxic shock syndrome, and we'll go through some of the interesting literature reviews. So starting with the streptococcal infection is a group A streptococcus, or it's also called as a Streptococcus pyogenes. It's an anaerobic gram-positive coccus, most commonly associated with pharyngitis or skin infection and soft tissue infection. It's not typically associated with invasive infection in general. However, less commonly, group A streptococcus can cause invasive disease, and this invasive disease refers to infection in the setting of culture isolation of group A streptococcus from a normally sterile site, most commonly the blood and less commonly other body fluid sites such as pleural, pericardial, joint, or cerebrospinal fluid. Forms of invasive group A streptococcus infection include necrotizing soft tissue infection, pregnancy-associated infection, bacteremia, and respiratory tract infection. And in terms of the epidemiology of the group A streptococcus, there is an estimated 3.5 cases of invasive group A streptococcus infection per 100,000 persons. This is in high resources countries, with a high case fatality rate of 30 to 60%. And the incidence is highest among the middle-aged group, more than 50 years, and in the extremely young age group, less than 1 year of age. Recently, in the last few years, since 1980s, there has been increase in the frequency of group A streptococcus infection, and this has been attributed to the increase in the frequency of 2 presentations of invasive group A streptococcus disease, which is a pregnancy-associated and a deep infection at site of muscle or blunt trauma, and the absence of any clear portal entry. Risk factors for invasive group A streptococcus infection include minor trauma that result in muscle bruising or hematoma, drugs such as nonsteroidal and corticosteroid, recent surgery, infections such as HIV and other viral infection, use of intravenous drugs, pregnancy and postpartum, cardiovascular disease, immune-compromised situations such as diabetes, burns, obesity, and also there has been a reported literature of intrauterine device causing group A streptococcus infection. One of the serious and life-threatening complication of severe invasive group A streptococcus infection is a toxic shock syndrome. So what's toxic shock syndrome? It is a condition characterized by shock and multi-organ failures, and it occurs as a result of capillary leak and tissue damage due to release of inflammatory cytokines induced by streptococcal toxins. And it developed in up to 1/3 of patients with invasive group A streptococcus, and the rate of toxic shock syndrome among patients with necrotizing fasciitis is as high as 50%. Toxic shock syndrome usually manifests as an early onset of shock within a few hours from the onset of the course of the disease, with multi-organ failure and a severe hypotension that's refractory to aggressive resuscitation. Fever is common, however, hypothermia may occur. Altered mental status occur in about 50% of cases. Influenza-like symptoms such as fever, malaise, nausea, vomiting and diarrhea in about 20%, diffuse erythematous rash in about 10%, and multi-organ failure, and also adrenal infarction leading to adrenal insufficiency, and the condition described as Waterhouse-Friderichsen syndrome. In terms of the diagnostic criteria for toxic shock syndrome, it can be subdivided into clinical and laboratory criteria. And both these two criteria should be present to diagnose the toxic shock syndrome. So in terms of the clinical criteria, it includes hypotension, plus 2 or more multi-organ failures and/or soft tissue necrosis. And in terms of the laboratory criteria, it includes isolation of group A streptococcus from a normally sterile site, most commonly blood, as I said, and less commonly other body site fluids such as cerebrospinal, pleural, pericardial, peritoneal, tissue biopsy, or surgical wound swabs. And when it comes to the management of toxic shock syndrome, it includes both the management of septic shock, medical management of septic shock with aggressive resuscitation, IV antibiotic, and also surgical debridement of infection if required. For suspected cases of streptococcal toxic shock syndrome in which the blood culture is still pending, then vancomycin or clindamycin can be used, and either a combination drugs containing a penicillin plus beta-lactamase inhibitor or carbapenem. Whereas in cases with confirmed streptococcal toxic shock syndrome by blood culture, then by blood culture or any other site fluid culture, then a combination of penicillin G and an antibiotic that suppresses protein synthesis, such as clindamycin, should be used. The duration of antibiotic therapy should be guided according to the clinical situation and the clinical response to the treatment. And also, IV immunoglobulin can be used in refractory cases of the shock. And also, it has been well recognized that group A or invasive group A streptococcus can occur during pregnancy and peripartum period. In fact, there is about 20 times higher rate of incidence of group A streptococcus in a pregnancy than a non-pregnant or postpartum patient. Risk factor or the source of infection include upper respiratory tract infection, premature rupture of membrane, or acquired from household contact. The exact pathogenesis or the pathophysiology of the infection is unclear. However, it has been postulated that there are certain pathophysiology behind the invasive group A streptococcus in a pregnancy, such as compromised mucosal barrier, altered vaginal pH, genetic susceptibility, and also some virulence factor. And as I said, group A streptococcus can cause invasive infections such as endometritis, necrotizing fasciitis, and patients who develop signs and symptoms of capillary leakage have a 3.5 times higher relative risk of adverse outcomes compared with those without such findings. And the early postpartum group A streptococcal endometritis, which means that in the first 4 days after the delivery, has high mortality risk up to 60%. Following slide is about few interesting literature reviews about the group A streptococcus in a pregnancy and peripartum period. The first case report is about a death of 16-year-old woman due to severe and significant group A streptococcus at the third trimester at her 37 weeks of gestation. The second case report is an invasive postpartum endometritis related to group A streptococcus in 41 years old women who presented 5 days after a normal delivery without any complication during the delivery. And according to literature reviews, there has been 15 cases of group A streptococcus postpartum endometritis, 1 reported death, and 13 out of those 15 cases had uncomplicated vaginal delivery and no preceding source of infection during the pregnancy. The third case report is about a severe toxic shock syndrome secondary to septic miscarriage. And this case report has highlighted the importance of using of the recombinant activated factor 7 to treat the intractable disseminated intravascular coagulopathy and the refractory shock. The fourth literature is about nationwide study of mortality and survival in a pregnancy related to streptococcal toxic shock syndrome. This study involved 13 dead cases and 15 surviving patients from toxic shock syndrome. According to the study, the rate of the fetal survival was parallel to the rate of the maternal survival. There has been higher number of fetal survival among the group of those women who had survived from toxic shock syndrome. The study has also strongly recommended the early administration of antibiotic, which means within 1 hour after the fulminant streptococcus toxic shock syndrome onset, as this can affect in terms of the prognosis and the outcome of the case. And also, it is vital and important to early recognize any household or any sick contact in the family, as this lead to early intervention and possibly a better survival of the case. The fifth case report is demonstrating a successful treatment of severe acute respiratory distress syndrome due to a group A streptococcal infection in the 3rd trimester. So this is a case report of 31-year-old woman in a shock who presented in a shock state at 31 weeks of gestation, and also presented with a fetal demise. Few hours after her presentation, she developed a brief episode of pulseless ventricular tachycardia, for which a veno-arterial extracorporeal membrane oxygenation has been used, and this has significantly or dramatically improved the outcome and the survival of the women. Also, there has been a reported case of toxic shock syndrome due to intrauterine device. And according to the study, it's important to early remove the intrauterine device, and also early surgical consultation and aggressive medical management for toxic shock syndrome, as I explained. Regarding the toxic shock syndrome and gynecological surgery, yes, there is a correlation between or few reported cases of toxic shock syndrome secondary to gynecological surgery. The first case report is describe a case of toxic shock syndrome in 37-year-old women after a laparoscopic cystectomy. And the second case report is an interesting one of severe life-threatening group A streptococcus secondary to Coalesce surgery. So the case report was about 37-year-old woman who was already immune compromised due to psoriatic arthritis, and she had a Coalesce as part of investigation for secondary infertility. And then she developed after the surgery a group A streptococcus and toxic shock syndrome, and subsequently she had a laparotomy for pelvic infection, but she had a good outcome from the infection. And few months later, she had an IVF pregnancy and resulted in a well, healthy baby. Take-home message: toxic shock syndrome is a rare but seriously potentially fatal condition. Usually, the diagnostic criteria overlaps with sepsis, and therefore high index of suspicion and awareness required to early detection and diagnosis and management of toxic shock syndrome. Multidisciplinary team approach is vital in treatment of the toxic shock syndrome, and also it has high mortality and long-term adverse sequelae, and the family should be carefully counseled with regard to this. And that's all, and I'm welcoming any questions.
Thank you, Dr. Lara, for your presentation. So anyone having any questions? So no questions. Thank you once again for your presence and
Thank you.
presentation.
Thank you so much.
Yes. Thank you. So, as our next presenter, Dr. Mikhail, cannot able, I mean, now he cannot able to attend. So, Dr. Immaculata Blasi from Azienda USL IRCCS di Reggio Emilia, Italy, is interested to present now. So, I'm going to make you the presenter, Dr. Immaculata. Hello, Doctor.
Yes, hello. Can you hear me?
Yes. Hi.
Yes.
Uh,
Hello. I would like to. I am a speaker of the on the theme by Mikhail Kostinov, impact of
okay. Okay.
vaccination. Yes. Yes.
Okay. So, you are going to
Uh,
present now?
yes. Of course, but I can share my screen.
Sure, sure. Actually, we got a message that he is not going to present, so we requested another speaker. So, not an issue. I am going to make you the presenter. Yes. So, please click
Okay.
on the share icon.
Okay. Oh, can you? Uh-huh. Okay. 5.
Yes, I can
Can
able to see the
yes.
screen. Perfect. Please continue.
Yes, thank you very much. Good afternoon, dear colleagues. My name is Ristitsa Kostinova, and first of all, I would like to thank the organizers for the opportunity to be a speaker at this international conference on gynecology and obstetrics and to share with you our scientific data together with Mikhail Kostinov and Alexander Cherdantsov. The theme of our report is impact of vaccination of pregnant women with immunoadjuvant influenza vaccine in the antenatal and early postnatal periods of children development. So, influenza is one of the most common viral infections resulting in pregnancy complications like premature birth, fetal disorders, such as congenital abnormalities, central nervous and respiratory systems disorders, and disorders of postnatal development, such as fetal growth retardation. Therefore, prophylactic vaccination of pregnant patients is a priority adopted by the World Health Organization and other scientific and medical organizations from various developed countries. Up to 10% of all hospitalized patients with severe influenza are pregnant. Pregnant women with flu are 10 times more likely to be treated in an intensive care unit. Perinatal mortality is 5 times higher among infants born to women who had influenza during pregnancy, and high mortality due to increased stillbirth rate, 27 on 100 births compared to 6 on 100 on 1,000 births from uninfected women. During the influenza pandemics of the beginning of the century and in 1957, the mortality rate among pregnant women infected with influenza exceeded up to 50%. This value was especially high among women in late pregnancy. Influenza epidemic over the 2009 and 2010 confirmed that pregnant women are the main risk group for the development of complications and mortality from infection. How does the influenza virus affect women during pregnancy in different trimesters? Regardless of the trimester when they got the flu or acute respiratory infection, placental insufficiency developed in everyone. The worst is in the second and third trimesters. Fetal hypoxia, also statistically significant, occurred in all trimesters, but especially in the last trimester, and it's reflected in the subsequent neuropsychic development of the child. It's important to note that addition of influenza in the first and second trimesters was accompanied by the development of preeclampsia in women. In all children, adaptation is disturbed. Cerebral ischemia occurs if women caught a flu or acute respiratory infection in the second trimester. Congenital anomalies of fetal development in pregnant women who have had acute respiratory infection and influenza at different gestational ages are ventricular septal defect, regardless of the trimester when the mother had a flu, but most often in the first, of course. And club foot is the problem if the mother caught a flu in the first trimester. Polydactyly in the second trimester and syndactyly in the first trimester. Spina bifida and timomegalia on the first trimester. Lobar form of holoprosencephaly and internal and external hydrocephalus on the second trimester. So, if in 2009 and 2010 pandemics there was an average of 4 to 6 cases of anomalies per 1,000 births in the world, then in Russia during the pandemics the frequency increased by almost 10 times up to 59 cases of anomalies per 1,000 births. Vaccination of pregnant women using the subunit and split influenza vaccines is routinely performed in a number of countries of Europe and America for over 20 years, and the vaccine efficacy reaches from 70 to 85%. Clinical studies have shown that vaccination of pregnant women using modern inactivated influenza vaccines neither affect the course of pregnancy and fetal growth, nor cause undesirable post-vaccination effects. It was found that vaccination of pregnant women using inactivated influenza vaccines leads to 50-63% reduction of flu-related morbidity among infants up to 6 months of age. So influenza has long been recommended for vaccination in the second or third trimesters, depending on an appropriate epidemiological situation. It's also possible in the first trimester, as fetal risk for immunizing agent isn't confirmed. In Russia, during the pandemics in 2009-2010, pregnant women were recommended to be vaccinated against influenza. Then only in 2014, these recommendations were included in the national calendar of preventive vaccinations for all pregnant women. Vaccination is the only method of safe and effective prevention of influenza in pregnant women, performed for over 30 years with subunit and split vaccines. The effectiveness of influenza vaccination in pregnant women with subunit vaccines reaches, as I have already said, 80%. According to the World Health Organization, pregnant women are the first priority group to be vaccinated against influenza. The chance of stillbirth in vaccinated pregnant women is 51% lower than in women who haven't been immunized, and this is on 58,000 births. For immunization of pregnant women, the split vaccines was used first, then the subunit vaccine, and the last in this chronology, the effect of the MF59 adjuvant was studied. And in our study, the immunoadjuvant polymer subunit vaccine was used, a new class of vaccines that wasn't previously studied in the world. The use of a new class of vaccine is provided by the WHO strategy, which you can see on the slide. A long-term goal is the development of universal vaccine that generates an immune response to all variants of the influenza virus, regardless of antigenic drift. Examples of implementation of the World Health Organization strategy in the world over the past years. Immunogenicity was achieved due to adjuvants, and the mechanism of action of which we don't have time to discuss, unfortunately, within the framework of this conference, but polyoxidonium acts mostly on the cellular immunity, has less reactogenicity due to a decrease in the dose of antigen in vaccines by 2 to 4 times, and search of alternative route of administration continues. There are many adjuvants in the world, but in practice, their use is very limited due to pronounced reactogenic properties. What are the mechanisms of action of adjuvants? Adjuvants change the dynamics of the formation of the immune response. They accelerate reactions and increase the level of antibodies, increase the duration of immunity. Adjuvants, depending on their properties, stimulate humoral and cellular immunity or simultaneously both types of immunity. So efficacy and safety of vaccination in pregnant women. The unfavorable epidemiological situation with influenza that occurred in 2009 has accelerated the development and implementation in healthcare practices of adjuvant-containing pandemic influenza vaccines such as Fluad that contains squalene and Riponrix that contains squalene and alpha tocopherol acetate, which confer enhanced immunogenicity. Adjuvants accelerate, change the dynamics of development of the immunity and increase its level in the duration of persistence of post-vaccination antibodies. With the help of an adjuvant, durable and solid immunity is achieved by administering small doses of antigen and a less number of injections. In Russia, 2 adjuvant-containing subunit influenza vaccines have been developed. They are monovalent pandemic and trivalent preparations. These drugs, in contrast to non-adjuvant subunit vaccines against influenza, like Agripalis 1, that contains 15 milligram strains of influenza viruses type A and B, have 5 milligrams of both strains of influenza virus and an adjuvant, polyoxidonium. In clinical trials, immunoadjuvant vaccines demonstrated high efficacy and safety in children aged 6 months and older and in adults. The trivalent adjuvant-based influenza vaccine is used in clinical practice for more than 20 years. In experimental studies, these vaccines showed no teratogenic effect on the development of fetus. Despite extensive use of these vaccines for specific prevention of influenza in Russia, studies on their safety in pregnancy haven't been conducted until recently. The information on the effect of adjuvant-containing vaccines on the fetus and postnatal development was missing. The information on vaccine immunogenicity for pregnant women and different gestational age, as well as vaccine ability to confer an adequate passive immunity to a fetus, was insufficient. Evaluation of the clinical course of the early post-vaccination period has shown that hyperemia in injection site was more often in the group vaccinated with Gripol Plus BC placebo, and on the contrary, fatigue was more common in the group with placebo. Monitoring of fetal development was carried out using a complex of measures which included analysis of markers of fetoplacental complex and ultrasound fetometry. In all groups of women in the early and late post-vaccination period, no changes in the basic parameters of embryo and fetogenesis have been found. Changes in the above parameters didn't depend on the type of influenza vaccine that was used and corresponded to the gestational age, like second and third trimester of pregnancy. Thus, for example, the TBG level in all groups, including placebo control of women vaccinated with the in the second trimester of pregnancy, was significantly lower than in the third trimester. and a direct relationship was found between the TBG and AFP concentrations, with TBG levels rising as pregnancy progresses. The chronic CG levels were dropping during the follow-up and inversely correlated with the TBG levels. All serum markers had no deviations from the reference values and reflected physiological changes in pregnancy. In the majority of cases, pregnancy resulted in physiologic birth. In a fraction of women, their pregnancy terminated prematurely with the birth of preterm babies, which corresponds to the preterm birth rate in the Ulyanovsk region of Russia, where the study was taking place. Such outcome was due to the obstetric pathology, which was unrelated to prior vaccination. Also, cases of birth of babies with perinatally acquired neurological impairment were mostly associated with gestational immaturity, and a part of babies had the intrauterine infection-like syndrome and developmental abnormalities and defects in up to 5% of cases. That correlates with the mean levels across the Ulyanovsk region, and it's 5.9%. Owing to the above abnormalities, such babies were excluded from further study. The early neonatal period of infants born to mothers vaccinated during pregnancy had a comparable dynamics between the groups. It was shown that immediately after birth, the number of babies with Apgar score of 9 points was similar between the groups, which attests to the overall good functional maturity. The period of adaptation in newborns passed without complications. So parameters of neuropsychological development, or NPD, of children born to vaccinated mothers didn't differ significantly from those of the placebo group. Overall, no changes of NPD have been observed in 81% of Group 1 infants in their first 6 months of life who had been born to mothers vaccinated during pregnancy with a monovalent influenza vaccine. In other clinical groups, this parameter was 83% in Group 2, 78% in Group 3, and 77% in Group 4. Within the structure of occasional NPD disorders, there were conditions which number didn't exceed the average statistical rate of neurological pathology in a given pediatric age group. It was noted that infants born to women vaccinated during pregnancy with trivalent influenza vaccines were 1.8 times less likely to develop non-influenza respiratory infections within the first 6 months of life as compared to infants from placebo control group. We registered the incidence of influenza-like respiratory infection in 79 mother-infant pairs. No difference in infection frequency was found during follow-up in these pairs, both during pregnancy and within 3 months after birth. Antibodies for protection against three strains of influenza virus were evaluated in hemagglutination inhibition reaction. The serum evaluation for Group 1, it's a group of mother-infant pairs vaccinated with Gripol Plus during pregnancy, at days 2-3 after birth demonstrated similar levels of protective antibodies for all influenza strains, ranging from 53% to 78%. The number of children with protective levels of antibodies was lower than the number of mothers with protective levels. However, the difference wasn't significant. Similar changes in the protective antibody levels were demonstrated in the group 2, its mother-infant pairs vaccinated with Agripales 1, ranging from 57 to 91% for various influenza strains. 3 months later, in Group 1, the post-vaccination levels of protective antibodies against 3 influenza strains detected in hemagglutination inhibition reaction in the mothers was similar to the levels detected within 2-3 days after birth. The number of infants with protective levels of antibodies decreased from 53 to 21% for H1N1 strain, from 62 to 12% for the H3N2 strain, and from 59 to 15% for the B strain. It demonstrates the physiological decrease of mothers' antibodies due to their catabolism. 3 months later, in Group 2, the post-vaccination levels of protective antibodies against the 3 influenza strains in the mothers was similar to the levels detected within 2-3 days after birth. A similar decrease in the number of infants with the protective antibody titer was found. Strain H1N1 from 61 to 34%, strain H3N2 from 57 to 30%, and strain B from 80% to 42%. This decrease of antibodies level is physiological too. Therefore, on the first day after birth, the titers of protective antibody targeting various influenza strains were found in 43% of patients from Group 1 who received the polymeric subunit influenza vaccine during second and third trimesters, and in 57% of patients from Group 2 who received the subunit influenza vaccine during second and third trimester. No significant differences was found for the mother-infant pairs. Within 3 months after birth, similar levels of protective antibodies were found in the mothers from both groups. For the infants, the titers of the transplacental post-vaccinational antibodies to all of the influenza strains were decreased due to physiological catabolism independent of the vaccine used. Observation of children within 6 months after childbirth showed that respiratory infections in those vaccinated with 3-valent vaccine, regardless of the production technology, the frequency of respiratory infections was 2 times lower or less than in children born from unvaccinated mothers. That correlates with the data from foreign research. So when we preparing pregnant women for vaccination, it's necessary for an obstetrician gynecologist to establish psychological contact to provide information about the risks and complications of influenza for the mother and the development of the fetus. The doctor should be confident in his data and knowledge, and with the aim to convince that vaccination will not affect the growth and the development of the baby. Furthermore, by vaccinating the mother, the protection of the child is also observed for 6 months of life, when it's still impossible to vaccinate the baby. So in conclusion, I would like to highlight that obstetrician gynecologist is the central figure in determining the policy of vaccination in pregnant women, and the doctor should always remember that the main principle of his work should be the prevention of the diseases and the treatment of vaccine preventable infections, correcting the mistakes made in preventive measures. So thank you very much for your attention. That's all that I wanted to talk about concerning the problem of the topic.
Yeah, thank you, Dr. Kostinova, for your presentation. So, anyone having any
Thank you.
questions? No questions, I think. Thank you once again for your presence and
Thank you very
presentation.
much. Thank you.
Thank you. Okay. So our next presentation is from Dr. Ayler Asambayeva from IM Shena First Moscow State Medical from Russia. And the title of the talk is Titanium Mesh Implants in Laparoscopic Correction of Apical Prolapse. Hello, Dr. Asambayeva.
Hi, hello.
Yeah, hi. So I'm going to make you the presenter.
Yeah,
You
sure.
just need to click on the share icon on your screen, then you can able to share your screen with us.
Mm-hmm. I have MacBook, so it will just take
Okay, then
time.
you have to go to system preferences. You
Mm-hmm.
have to give the permission. Then you need to
Mm-hmm.
log out from the session. Again, you have to log in, then it will work.
Okay.
Sure.
I'm back.
Yes, yes. And you are the presenter also. Please click on the share icon.
Okay, sure. Mm-hmm. One sec. Mm-hmm. So my camera is on, right?
Yes.
Okay, great.
You can make it a full screen and
Yeah,
start
sure.
presenting.
Can I?
Perfect. Yes.
Okay, good. Thank you so much. Greetings, dear colleagues, participants. My name is Aylar Asambayeva, and I am a PhD student in the Department of Obstetrics and Gynecology in the First State Moscow University in Moscow. I'm really glad to be a part of such an amazing and huge conference. Thank you for giving me an opportunity. So today I'm presenting our research, titanium mesh implants in laparoscopic correction of apical prolapse. So let me just briefly talk about the definition. Pelvic organ prolapse is a downward descent of female pelvic organs, including the vagina walls, uterus, related organs, and post-hysterectomy vaginal cuff. In the structure of gynecological diseases, this pathological state reaches approximately from 28 to 39%. In 2009, there was actually an article published stating that the pelvic organ prolapse is a serious health problem nowadays and in the near future. Well, as it may be seen from the bar diagram, the number of elderly patients suffering from pelvic organ prolapse at the time of 2020 varies from 40 to 60%. And by 2050, the number of women suffering from complete genital prolapse between the ages of 50 and 79 will be actually doubled, approximately to like 46%. So here in the slide, we present some risk factors of pelvic organ prolapse, and they are divided into four groups: predisposing, initiating, contributing, and decompensating. So as an initiating factor, it could be also as a hysterectomy. So talking about apical prolapse, it is actually one of the most significant issues of the modern gynecology. It is a descent of uterus, cervix, or vaginal wall. The main cause of apical prolapse is actually weakening and or it could be also a defect of the ligamentous apparatus of the pelvic organs. Well, but the problem is still remains significant because currently various surgical techniques are used for the treatment of uterine prolapse, including some of the surgeons use synthetic implants, or they use self tissues. But there is a very high recurrence rate, and it ranges from 40 to 60%. There is also mesh-associated complications in such patients, and it remains from 1 to 20%. So the objective of our research is to study the efficacy and to assess the safety of the use of titanium ribbon-like implants for surgical correction of apical prolapse, second and third stage. Here in this slide, we present some medical parameters, some technical and medical parameters of titanium mesh endoprothesis. I would like to talk about a few of the parameters. So the length of the implant is around 200 to 255 millimeters. There is actually a slight relative elongation, which prevents the re-prolapse of the organs that I was talking about. And there is also low flexural stiffness in any direction, which actually helps to avoid the tissue injury. There is high tissue adhesion of surgical wound and very high resistance in aggressive environments. Here in this slide, we present some advantages of titanium endoprothesis. It has a biological inertness. There is a high degree integration with the connective tissue. There is a high plasticity. There's low fuse. There's lack of initiation of aseptic inflammation, lack of immune system response to the endoprothesis. There is actually a formation of collagen type 1 on the titanium implant. As a result, there is a formation of mature connective tissue and a thin but still dense scar. And there is, most importantly, there is no structural changes during long-term follow-up. So in our clinic, we had 38 patients, ages from 29 to 76 years old. So the patients were reproductive, premenopausal, and postmenopausal period. So these patients, they underwent a clinical examination that is a very standard examination, such as physical examination, as well as lab and instrumental examination. So in order to correct their apical prolapse, there was a three-stage organ-preserving surgical program by laparovaginal approach developed and implemented. In the first group of patients, we had 17 patients that were diagnosed with apical prolapse, second and third stage. We performed a bilateral subperitoneal hysterosuspension using ribbon-like titanium mesh implant. In the second group of patients, there were 13 of them. Other than apical prolapse of second and third stage, they had uterine fibroid. Thus, we performed a bilateral subperitoneal cervicosuspension using ribbon-like titanium mesh implants after subtotal laparoscopic hysterectomy. In the group 3, there are 8 of patients. They had post-hysterectomy prolapse of vaginal calf, and they underwent bilateral subperitoneal colposuspension using ribbon-like titanium mesh implant. So now let me please tell you a little bit more about the surgical technique that we performed. And the first stage was bilateral subperitoneal implantation of ribbon-like titanium endoprothesis with the fixation to the side walls of the uterus, cervical stamp, or vaginal calf. So we introduced 3 trocars at the typical points. After that, we inspected the pelvic organs. Then through the additional punctures, we made the 2 centimeters lateral and below the trocar holes using the metallic, using the metallic trocars, we introduced our titanium mesh implants with the conductors. These implants actually were 20 centimeters long and 1 centimeter wide. So under laparoscopic control, this implant with an oval end was placed subperitoneally under the round ligament on both sides of the uterus, and the implants were sutured to the lateral walls of the uterus with the non-absorbable ligatures. Here in the picture, you can see the first step, going through all the last step. So in the second stage and in the second and third group of patients, we actually performed the same procedure, but the fixation of the implant was to the cervical stamp and vaginal cuff. The second stage of our operation was reposition of physiological position of the uterus, cervical stamp or vaginal cuff, and was made by pulling and fixation of the peripheral ends of titanium mesh implants. After that, we cut off the excess, leaving aside just 2 centimeters of our implant above the skin. Then this excess, we bent it and immersed it above the aponeurosis in the opposite direction. The third stage of our program included the strengthening of the pelvic floor. We performed colpoperineography and levateroplasty. Here in the slide, we present some parameters of the intraoperative and postoperative follow-up. So the duration of the surgery was from 40 to 90 minutes. The blood loss was varying from 50 to 150 milliliters. After 1 month of the surgery, 18 patients had complaint of irregular pooling, and only 6 patients had increased urge to urinate. So dynamic outpatient follow-up was actually happened after 1, 3, 6, 12, 24 months. So the result was like that. We made a questioning survey of the patient, and it showed us a satisfaction of the patients with the result of surgical treatment. It had a positive effect to the quality life, mood of the patient, and it contributed to an increase in the social and sexual life of sexual activity of the woman. In the late postoperative period, during the gynecological examination at rest, we also performed a Valsalva maneuver. We did ultrasound of pelvic organs, transperineal and transvaginal. There was no displacement of the pelvic organs detected, and there were no mesh-associated complications. As the conclusion, we would say that laparoscopic bilateral subperitoneal, hysteria, cervica, and colposuspension to aponeurosis using ribbon-like titanium mesh implants actually contribute to an increase in the effectiveness of surgical treatment of various forms and severity of apical prolapse. Thank you for your attention, and thank you so much for the interest to the work of our department. And I would like to say a huge thanks to the head of our clinic and the head of my research program, Anatoly Ivanovich Ishchenko, and my consultant, Irina Dmitrievna Khokhlova. Thank you so much.
Thank you very much, Dr. SM Bayeva, for your presentation. So, anyone having any questions?
Excellent presentation and the work. I'm Dr. Said, and I just want to know, is this the trial you guys are doing, or is it in clinical practice?
Okay, thank you very much. Anyone else have any questions?
I'm right back here. Yeah, sure.
No questions. Then thank you once again for your presence and
Yeah, sure.
presentation.
Thank you so much.
Thank you. So, as our next presenter is not there, so we'll go to the presentation by Dr. Immacolata Blasi from Italy. And the title of the talk is Correlation between parameters of glycemic variability and fetal growth, neonatal hypoglycemia and hyperbilirubinemia in women with Gestational diabetes. Hello, Dr. Immaculata. Can you please
Hello,
unmute
everybody.
yourself? Yeah, hi.
Hello,
So
everybody.
you are the presenter now. Please share your screen with us.
Bye.
Yeah, previously it was visible. Now it is closed.
Okay.
Yes, now it's perfect.
Okay.
You can make it full screen.
Good
Perfect.
morning. Okay. Good morning to everybody. My name is Dr. Immacolata Blasi. I'd like to thank people behind the Second International Congress for inviting me to give this presentation. My talk is about the correlation between parameters of glycemic variability and fetal growth, neonatal hypoglycemia, hyperbilirubinemia in women with gestational diabetes. Gestational diabetes range between 2 to 7% in Europe and USA, and is above 18% in Southeast Asia. During pregnancy, insulin sensitivity decreased to 50 to 60%, and compensatory insulin production is almost twice as high in pregnancy comparing the non-pregnant state. So women with GDM show inadequate insulin production because of the inability of beta pancreatic cells to compensate insulin resistance. We know that women with gestational diabetes have an increased risk for preeclampsia, cesarean section, fetal distress, fetal macrosomia, hypoglycemia, hyperbilirubinemia, stillbirth, neonatal intensive care admission, and later higher likelihood of developing diabetes type 2. In 1993, researchers asked if gestational diabetes was a myth, it was an entity, and then then the Apple study demonstrated a continuous association between increasing maternal glucose level and adverse perinatal outcome. So careful monitoring of blood glucose level and maintaining them as close as normal as possible are essential in care of patients with gestational diabetes. Still now that management of diabetes is changed, the risk of macrosomic fetus in women with diabetes type 1 and 2 range between 48 and 62%. And this risk is 2-3 times higher in women with gestational diabetes than general population. So that's why the introduction of parameters of glycemic variability to ameliorate maternal and neonatal care. What is glycemic variability? It's a measure of glycemic fluctuation from peaks to nadir. And researchers think it should be a target on treatment of glycemic disorder encountered in patients with diabetes type 2. So we can, in 2008, Monnier published an article asking if we should consider this glycemic variability as a component of dysglycemia, if it was important, if we do have an appropriate tool for assessing glycemic variability, and if we should recommend the measurement of glycemic variability in clinical practice. Dysglycemia includes sustained chronic hyperglycemia, but also but also fasting and postprandial glucose increase and acute glucose fluctuation. And it looks like glycemic variability increase the effect more than sustained hyperglycemia, because there is an increase of protein glycation and an activation of oxidative distress. These conditions were evaluated by dosing the urinary excretion rate of 8-isopGF2 2, that is a marker of oxidative distress and positively correlated with MAGE, that is a marker of glycemic variability. And also, the production of nitrotyrosine was significantly increased at fasting in patients with diabetes, but additional increase was seen during post-meal periods. This so excessive protein glycation and activation of oxidative stress lead to vascular endothelial dysfunction, specifically micro and macrovascular complication. Many studies demonstrate that glycemic variability is associated with endothelial dysfunction and platelet hyperactivation. And so researchers define that glucose variability should be a target of clinical intervention, because higher glycemic variability can lead to impaired nitric oxide activity and enhanced reactive oxygen species production. We should remember that nitric oxide is considered an important anti-atherogenic molecule that is necessary to contain diabetic endothelial alterations. Fluctuant hyperglycemia have a higher risks of chronic vascular complication than persistent hyperglycemia. And a study about Esposito showed that hyperglycemic spikes increase circulating cytokine concentrations more than continuous hyperglycemia, at least in the short term, and suggests an oxidative mechanism mediates the effects of hyperglycemia. Indeed, administration of glutathione completely prevents rise in plasma cytokines, particularly they analyzed the increase of level in interleukin 6, 18, and tumor necrosis alpha, and even if the molecular mechanism triggered is not known, however, some metabolic variation induced by sustained hyperglycemia may change or feedback regulatory cell controls, partially counteracting the glucose effects. Intermittent exposure to hyperglycemia might reduce such adaptation, causing more pronounced toxicity. And consistent with this, they found that the culture in human umbilical vein cells, apoptosis, was enhanced in response to intermittent rather than continuous high glucose concentration. And so the exposure of increasing glycemic fluctuation reduced the antioxidant cellular defense, increasing diabetic complications. In another study done in rats, they show that the fluctuation of glucose induce more deleterious effects on monocyte endothelial cell interaction and intimal thickening than did consistent glycemic exposure in vivo, and even the exposure duration has an effect on the adhesion. Although the extrapolation of animal experience to diabetic patient is premature, the data suggests that inhibition of fluctuations in circadian glucose concentrations is a potentially important goal, along with the reduction of glycated hemoglobin in the prevention of cardiovascular disease in diabetic patients. And what about women with gestational diabetes? Gestational diabetes women show an appropriate insulin response, which leads to abnormal glucose levels exposures and results in high levels of oxidative stress and inflammation. Fluctuation in blood glucose levels may drive excessive reacting oxygen species and oxidative distress, reduce nitric oxide, and increase expression of adhesion molecules, and may lead to inflammation and vascular complication, which give rise to maternal and fetal complications. There are lots of parameters of glycemic variability. We evaluated some of them that analyzed intraday and interday variability, such as standard deviation, MAGE, MODD, the mean value, the high blood glucose index, the low blood glucose index, the J index, and times in range. A recent review published in 2022 analyzed the study performed in gestational diabetes, evaluating the glycemic variability, except for two studies. All of them found a significant relationship between parameter of glycemic variability and neonatal and maternal outcome. Particularly, there was a study about the evaluation of parameter of glycemic variability in gestational diabetes and the association with beta cell function. So women, there were three groups of women underwent continuous glucose monitoring for 72 hours, and they underwent oral glucose test, and so the beta cell functions was assessed by OMA index, the early phase insulin secretion and second phase insulin secretion. In the continuous glucose monitoring, the MAGE and mean value increase progressively in the three groups, and in the MODD and standard deviation are higher in the gestational diabetes group. They increase in the same way in the other two groups. Beta cell function in the gestational diabetes group, there is an association between the early insulin phase secretion with the OMA index and the insulinogenic index. So glycemic variability in women with gestational diabetes was higher than in normal pregnant women, and the evaluation of MAGE correlates well with impaired early phase insulin secretion. Another study used the glycemic variability to treat the women. Particularly, there were two groups. One with the patient underwent routine care, and another underwent continuous glucose monitoring. The routine care group showed higher incidence of preeclampsia. The frequency of macrosomic or LGA fetuses was higher in the routine care group. Significantly fewer neonates in the glucose continuous monitoring experience hypoglycemia, hyperbilirubinemia, or fetal distress than in the routine care group. So the objective of our study was to investigate the feasibility of parameters of glycemic variability to predict complication in women with GDM. We include only singleton pregnancy with gestational diabetes, and they underwent diet therapy, and we instructed them to perform a self-blood glucose monitoring by fingertip blood test at home until delivery. So they weekly schedule the self-blood glucose at home, and the insulin therapy was given because of a trend in glucose level rise above upper than 95 milligram per deciliter at baseline, or more, or if glycemia was higher than 140 milligrams per deciliter after at least 2 weeks period of diet therapy. And women attended check every 2 weeks in case of insulin treatment and every 4 weeks in case of diet therapy. Glycemic data were collected to calculate parameters of glycemic variability, and maternal characteristics and data on pregnancy outcome were obtained for clinical folders. So we collect endpoints about obstetrics and neonatal outcome. So about neonatal outcome, we look about fetal weight, fetal length, Apgar score, gestational age at birth, hypoglycemia, hyperbilirubinemia requiring phototherapy, fetal distress, congenital malformation, shoulder dystocia, trauma during birth, stillbirth, and perinatal death. And then we collected the parameter of glycemic variability, specifically glycemic mean value, mean amplitude of glucose excursion, standard deviation, high blood glucose index and low blood glucose index, J index, and the mean absolute glucose. And we performed a statistical analysis on 12 pregnant women affected by gestational diabetes. The mean age was 36 years old and the mean BMI was in between 25 to 29.9. Participants gained a physiological weight in average, and the diagnosis was performed at 24 to 28 weeks, except for one woman who received the diagnosis at 16-18 weeks. All women underwent diet therapy and 3 women required also insulin therapy. According to standard clinical practice, all women treated with diet and or insulin therapy achieved acceptable blood glucose levels. Between the newborns, we found that macrosomia and large gestational age fetuses were identified in 3 babies, and hypoglycemia was found in 3 babies, hyperbilirubinemia in 4. 2 to 3 preterm babies were admitted to neonatal intensive care unit, and specifically 1 baby had respiratory distress, hypocalcemia, and sepsis. We compare parameters of glycemic variability between them, and we found a positive and statistically significant correlation of glucose mean with all other measures, but no with the glucose mean value and low blood glucose index. And a significant decrease over time occurred mainly for high blood glucose index measure. When we compare the glycemic variability to neonatal outcome, we found that talking about macrosomia, there were spikes in glucose mean value, MAGE, standard deviation, HBGI, and J index around 30 to 31 weeks. In the same weeks, we found spikes in glycemic mean, high blood glucose index and J index, and talking about hyperbilirubinemia, in the same weeks we found spikes in glycemic mean, high blood glucose index and J index. So, in conclusion, spikes in parameters of glycemic variability at 30-31 weeks of gestation are related to fetal macrosomia, neonatal hypoglycemia, and hyperbilirubinemia. Spikes on glycemic mean, high blood glucose index, and J index values are similar among all these 3 conditions and did not vary after adjustment for pre-pregnancy BMI and administration not of insulin therapy. It is therefore a huge importance to monitor glycemic variability in pregnant women affected by gestational diabetes. In line with previous publications, our results confirm the relevance of such parameters of glycemic variability. Further studies are needed to translate these experimental findings in clinical guidelines. So I want to quote a relevant argument of Ceriello. If the human body spends so much energy to maintain the blood glucose level within such a narrow range, it is because otherwise it would be very deleterious. Studies strongly suggest that the glucose variability plays a critical role as independent factor in worsening the prognosis in a number of other clinical settings. And we are still at the early days of glycemic variability research, and much more needs to be done. We are looking for collaboration to further study about glycemic variability, so please feel free to contact us. Thank you.
Thank you, Dr. Immaculata, for your presentation. So anyone having any questions? Okay. Okay, no questions. Thank you once again for your presence and presentation.
Thank you.
So our next presenter is Dr. Archana Kumari from Rajendra Institute of Medical Science, India. And the title of the talk is Placenta Acareta Spectrum, Diagnostic and Management Dilemmas in Low Resource Setting. Hello, Dr. Archana.
Yes, hi. I
Yeah,
just
hi.
wanted to share my screen.
Yes, yes. You need to click on the share icon.
Okay, I'll do that.
Yes.
Why my camera is not turning on?
That you need to
Camera,
check.
I'm not able
That
to
we
turn
don't
on.
have any access. We only can give you the sharing the screen access only.
Yeah, I'm
Camera you
checking
need
the
to check. Yes. Yeah, now
yeah,
it's
it is.
working. Camera. Yeah.
Yeah. So I need to share, no? Share screen.
Yes. Yes. Click on the share icon.
Yeah, I did that. So I go to my desktop.
Yes, it is visible. You can make it a full screen. I mean, you can open the presentation and make full screen.
Yeah. Why it is not happening? Just a minute. I'll first open it. Yeah, is it visible?
Yes, you can play from beginning.
Yeah.
Yes, perfect.
So am I visible and my presentation is also visible?
Yes, everything is visible and your voice is also audible. You can continue.
Okay. So do I have a time limit? No.
Yes, you need to complete in that.
So it is, I think, 25 minutes.
Yeah, 25 minutes. Yes.
Okay, and I am starting at 4:40. Okay, I'll try to finish in time.
Okay.
Uh, okay, so um, respected audience, the participants of this conference. I begin after expressing my gratitude and thanks to the organizer for giving me this opportunity to be a keynote presenter on this topic, placenta accreta spectrum, the diagnostic and management dilemmas in low resource setting. So I'll start with some real-time case scenarios. So here is one case who is 28 years old, gravida 3 para 1 plus 1, live 1, who was admitted in our institute at 24 weeks gestation of pregnancy with previous one cesarean section and ultrasound diagnosed placenta previa and percreta. She remained admitted till her planned cesarean hysterectomy at 34 weeks. So, as you can see in this hysterectomy specimen, the baby was delivered by a vertical incision on the upper segment. And of course, because it was a cephalic presentation, the baby was delivered by breech extraction. Most importantly, after the delivery of the baby, the placenta was not touched at all. The incision was closed, and decision to proceed for hysterectomy was planned. So here you can see it was a total hysterectomy. This is the cervix, and her post-operative period went uneventful. She was in HDU for 24 hours. but she was discharged after 7 days. Now, another case scenario, she was 38 years old, gravida 2, para 1 plus 0, whose first baby was delivered with cesarean section 10 years back. She had conceived spontaneously and was diagnosed as a case of placenta previa with percreta and was referred from the private hospital at 34 weeks, 5 days of pregnancy. She also had hypothyroidism and gestational diabetes mellitus. And of course, she was referred from a private hospital because the doctor in the private setup had gone on leave. So they referred it to the government hospital, which was the Avas hospital. So we did a planned cesarean hysterectomy. Everything was arranged, 3 units of packed red blood cells and FFP, fresh frozen plasma in hand. And here the incision was given on the upper end of the end of the placenta. Transverse incision, the baby was delivered, uterine incision closed, placenta was not touched at all, and a hysterectomy was planned. And cesarean hysterectomy was done, but of course it was a grade 3C placenta accreta. I mean, there was invasion into the bladder, into the surrounding broad ligament. And so during the section, bladder injury occurred, surgeon was called for help, and there was massive intraoperative hemorrhage to the extent of 2000, almost 2000 to 2500 liter, but it was replaced by blood. 8 units of blood was transfused. The patient was kept in ICU observation under strict monitoring, but she developed DIC and she went into irreversible shock and she died within 24 hours due to a multi-organ failure. So that was a major obstetric catastrophe. Here's another case who was gravida 4 para 3 plus 0. She had previous 3 sections and she was referred from a local private hospital at 35 weeks with bleeding PV, and she had come in a state of shock. Ultrasound had been done at the private hospital at twice almost, but it could only suggest that placenta was low lying. It did not mention about any degree of placenta accreta. So we, after correction of the shock, we took up her for cesarean delivery. 4 units of blood was transfused. Patient was taken for emergency cesarean. With 4 units of blood in hand, patient was taken for emergency cesarean, and intraoperatively we could diagnose it was a grade 3C placenta accreta syndrome, because we could see the placenta almost extending into the bladder and also into the surrounding organs. So quick total hysterectomy was done, of course, after the delivery of the baby. But here again, despite our best of effort, the patient could not survive. She died in an immediate post-operative period. So the problem was he was a previous 3 cesarean sections. Still, there was no regular ANC. Although ultrasound was done, but it was not a standard or quality ultrasound which could detect placenta accreta. It only mentioned about the low-lying placenta. Now, this is another case. It was diagnosed intraoperatively during the elective cesarean section of a previous 2 cesarean section. During attempt to deliver the placenta, it was found to be focally adherent. And as you can see in the arrow mark, this is a focal placenta increta it was, because the invasion was not visible through the serosal layer. So the attempt, actually the case was started by a resident. I was called in for help. She was trying to separate the placenta and it was bleeding profusely. So we took a decision to do a rapid cesarean hysterectomy. So cesarean subtotal hysterectomy was done. That patient went, uh, her post-operative period went uneventful and she was discharged with a healthy mother and healthy baby. So the out of the 4 cases, 2 was diagnosed intraoperatively, out of which we lost one mother. But in the first 2 cases, they were diagnosed in the antenatal period, but still we could not uh, help in one case and the mother died. So, with this background, I would like to say the placenta accreta spectrum is indeed an obstetric nightmare which is impacting maternal health outcome globally. With increase in cesarean section rate, the placenta accreta spectrum disorder have also increased and have become an important cause of maternal and fetal morbidity and mortality, as we discussed with the case scenarios. Women in developing countries are more likely to die from PAS because of the lack of access to the prenatal diagnosis and sometimes lack of the intensive care facilities. So, Placenta accreta can be used as a single pathological entity, or it can be used as a generic term for disease spectrum. Am I audible? Hello?
Yes, you are. We can hear you.
Yes, yes, it
Yeah.
is audible.
Okay, thank you so much. So placenta accreta can be used as a for single pathological entity, or it can be used as a generic term for whole of the disease spectrum. So when used singly, it refers to the placenta which attaches to but does not invade into the myometrium. The disease spectrum refers to all three grades of abnormal placental attachment: accreta, increta, and percreta. So sometimes we use the term abnormal invasion of the placenta instead of placenta accreta spectrum, and this refers to the penetration of the trophoblastic tissue through the decidua bacillus into the underlying uterine myometrium, the uterine serosa, or even beyond, extending to the pelvic organs. So etiopathogenesis is obviously the defective formation of Nitabuc fibrinoid layer, which normally limits the trophoblastic villi penetration. So we have already known that placenta accreta spectrum disorder includes accreta, which comprises the highest percentage, followed by increta, 12%, and percreta 6%. So this the three grades are visible beautifully in this diagram. But FIGO came with a classification, uniform classification for the clinical diagnosis of placenta spectrum disorders as grade 1, which is abnormally adherent placenta, which is also known as placenta adherenta or creta. Then grade 2 is abnormally invasive placenta, which is in creta. Grade 3 is abnormally invasive placenta, which is per creta. Grade 3A is per creta, which is limited to the uterine serosa. 3B, where per creta invades up to the urinary bladder, and grade 3C, where invasion occurs to the other pelvic tissue or organ, irrespective of invasion to the bladder. So these are in detail the FIGO classification for all the grades. This is grade 1, abnormally adherent placenta, and FIGO has set up clinical criteria and histological criteria as well. Clinical criteria is at vaginal delivery, there is no separation of the placenta with synthetic oxytocin. Any attempts for manual removal of the placenta results in heavy bleeding from the placental implantation site. And if laparotomy is required, of course, that would be the case in case of cesarean delivery as well. So it is the criteria same as here. Macroscopically, however, the uterus does not show any distension over the placental bed in the form of placental bulge. There is no placental tissue seen invading through the surface of the uterus, and there is no or minimal neovascularity. Histological criteria: when we do the microscopic examination of the placental bed sample from hysterectomy, it shows extended area of absent decidua, but the diagnosis cannot be made on just delivered placental tissue or on random biopsies of the placental bed. Then grade 2 clinical criteria can be, of course, only it can be at the time of laparotomy or during cesarean section because it is in creta. So at laparotomy, we can see the macroscopically over the placental bed bluish or purple discoloration, distension over the placenta, that is called placental bulge. Significant amount of hypervascularity would be there over the placenta. We can see the longitudinal blood vessels running over the uterine serosa. However, no placental tissue can be actually seen invading through the uterine serosa. Gentle cord traction, if we give, it will result in dimpling of the uterine wall. Histological criteria again, same. Hysterectomy specimen will show areas of placental villi within the muscular fiber or sometimes in the lumen of the deep uterine vasculatures. So in grade 3A, which is limited to the uterine serosa, it is obvious at the laparotomy that the placenta has invaded up to the uterine serosal surface. And however, there is no invasion to the other organ, including the posterior wall of the bladder, because a clear surgical plane can be identified between the bladder and the uterus. Histological criteria again, we can see the hysterectomy specimen will show the villus tissue within or breaching the uterine serosa. Then grade 3B, that is the placenta invading up to the urinary bladder. So at laparotomy, we can actually see the placental villi into the bladder. Clear surgical plane cannot be identified between the bladder and the uterus, and these are the cases where injury to the bladder is likely to occur. Histological criteria: hysterectomy specimen shows villus tissue breaching the uterine serosa and invading the bladder or reaching up to the urothelium. Now, grade 3C, here the invasion occurs to the other pelvic tissue and organ, and this is at laparotomy. It is visible that placental villi have extended into the broad ligament, vaginal wall, pelvic side wall, or other pelvic organ. Histological criteria: hysterectomy specimen will show the villus tissue breaching the uterine serosa and invading the pelvic tissue or organs. So after this classification of the clinical classification of placenta accreta, we should know about the risk factors. So risk factors could be maternal factors like advanced maternal age, multiparity, uterine anomalies, IVF pregnancy, placenta previa, smoking. All these can predispose to placenta accreta. Then previous surgeries on the uterus like previous cesarean section, hysteroscopic myomectomy, uterine artery embolization, previous curettage, or previous thermal ablation, prior pelvic irritation, previous trophoblastic diseases, all these can be a risk factor for the placenta accreta spectrum syndrome. So the triaging of the patient on the basis of a clinical risk factor is very vital in low resource settings. So, among all the risk factors which were discussed, placenta previa and previous cesarean section are the two most important recognized risk factors. In one of the systematic review, reported an increase in the incidence of abnormally invasive placenta from 3 to 4% in women with placenta previa with no cesarean section to as high as 50 to 67% in women with 3 or more cesarean deliveries. So this is one of the research article on the basis of our study. Uh, so what I want to highlight from this study is that in our case, it was the placenta increta which has the highest incidence, followed by accreta and praccreta, opposed to the literature which shows that placenta accreta is the commonest. And among the risk factor, a case of previous cesarean with placenta previa was found in 44% of the cases, which was the highest risk factor. So, coming to the diagnosis of, we can suspect placenta accreta spectrum disorders on the basis of risk factor, but how do we confirm the diagnosis? So it can be done with the help of good ultrasonography. So presence of gestational sac in the lower uterine segment can be an early sign of placenta accreta. Similarly, cesarean scar pregnancy could be an early sign of placenta accreta. Irregular vascular spaces in the bed, irregular placenta lacunae, loss of retroplacental clear zone, retroplacental myometrial thickness less than 1 mm, protrusion of the placenta into the urinary bladder. These are some of the important diagnostic criteria for ultrasound. So, what is the most specific sign? Actually, placental lacunae are considered as single most reliable feature with a high sensitivity and good predictive value for the diagnosis of placenta accreta spectrum disorders. And typically, these present as numerous irregular lacunae of different sizes, and there is a turbulent flow as opposed to the placental lakes that have a distinct outline and laminar flow. So, it is irregular placental lacunae with turbulent flow, which is most important and highest sensitivity for diagnosis of placenta accreta syndrome. Color Doppler will show the diffuse or focal turbulent flow, vascular lakes with turbulent flow, hypervascularity of the serosa at the urinary bladder interface. So this is a 3D view which shows hypervascularity, inseparable cotyledonal and intervallar circulations. So now the question is, how frequently ultrasound should be repeated, that too in a low resource setting. So ideally it should be done at 18 to 20 weeks. When we do a routine anomaly scan, then it should be repeated at 28 to 30 weeks and again at 32 to 34 weeks. So, considering there is a sizable inter and intra-observer variation in the interpretation of PAS, yeah, actually the patient who is screened with clinical risk factor, which we already discussed, they should be actually sent to experienced and expert ultrasonologists for a better diagnosis, for the confirmation of the diagnosis. So, is there any role of MRI, particularly in the low resource setting? Well, evidence shows that MRI has almost equals, it does not improve the findings of the ultrasound. So it is not routinely recommended. Even the ACOG does not recommend it routinely, and more so even in low resource setting, it is very difficult to do MRI. But MRI, if facilities are available, can be done when sonography results are inconclusive, when there is a posterior placenta previa, and whenever the extension into the serosa, I mean beyond the serosa is suspected, MRI can have a role. So MRI, these are the MRI findings. There will be heterogeneous signal intensity, dark intraplacental band on T2 weighted images, tenting of the bladder, visualization of the invasion of surrounding structure, loss of myometrial trilaminate structure. All these can be the signs in MRI for the diagnosis of placenta cretin syndrome. Is there any role of marker? Well, alpha fetoprotein, free beta HCG, human placental lactogen may have been studied. Maternal serum alpha fetoprotein more than 2.5 mmom. It is said that placenta creta increases eightfold risk. But ultrasound has fair diagnostic accuracy, so these biomarkers are not required at all, particularly in our low resource settings. So, why we are afraid or why we are worried of placenta accreta syndrome? We already discussed the cases through which we can know how it can contribute to maternal mortality. And of course, there we also saw it was due to mainly massive obstetric hemorrhage, DIC, uh, surgical injury to the ureter, bladder, bowel, and other neurovascular structures, sometimes ARDS, that is acute respiratory distress syndrome, because we do a massive transfusion protocol. There could be blood transfusion reaction, need for mechanical ventilation and ICU admission, electrolyte imbalance, renal failure, post-operative infection, thromboembolism, and of course the maternal mortality. So, if we are able to diagnose before delivery, are there any advantages? Yes, of course, because it allows to plan the delivery and helps in minimizing the maternal morbidity and mortality, and definitely improves the perinatal outcome. So, after we how we are planning to manage the case of placenta accreta syndromes. So, planning is very important after we confirm the diagnosis through scrutinizing the clinical risk factors and confirming it by the ultrasound or whenever MRI is required. Once the diagnosis is confirmed, we have to plan the delivery. Especially the place of delivery is very important in low resource setting. We have to counsel the patient to get delivered at the tertiary center where facilities of the blood bank and NICU, that is neonatal intensive care unit, is available, and where a multidisciplinary team can be assembled, including obstetricians, anesthesiologists, interventional radiologists, neonatologists, urologists, and hematologists. And of course, in our setting, anemia is so very common, so it is very important to build up the hemoglobin and correct the iron deficiency anemia. So there is extensive role, immense role of counseling in these cases, because we have to counsel the patient that they would need cesarean hysterectomy. Risk there is risk of profuse hemorrhage and even maternal death. That is, she requires ICU care. There is risk of visceral injury, especially the bladder and sometimes ureteric injury, and we have to arrange adequate amount of blood and blood products. So we have to counsel for the emergency preparedness, because our patients usually come from a remote village area where they are deprived of money, they are deprived of transport facilities. So we have to counsel them to be prepared for transfer to the tertiary care center with adequate arrangement of the money, resources, and what is the distance from the tertiary center. They have to arrange for the blood donors. Uh, all these emergency preparedness are very important. However, depending upon the social circumstances, for example, the availability of emergency transport services is not available 24 into 7. Patient is residing far away from the tertiary care center. These patients may opt for hospitalization until birth. When I was discussing the case, one of our patients got admitted in our tertiary center right from 25 weeks to 34 weeks till her delivery. And of course, we could save that patient. So, if the patient is already diagnosed and planned for delivery, we have to do preoperative investigation, including other than the routine antenatal investigation. We should be prepared with the coagulation profile. We should be prepared with a blood group and adequate number of cross matched and blood products. So, very important question: when to time the delivery? Elective cesarean delivery, in 90% of the cases we are going to do cesarean hysterectomy. So but what should be the timing of delivery? It should be anything between 34 to 36 weeks, at most 37 weeks, but not beyond 37 weeks. And of course, because we are planning to do a preterm delivery, we have to administer steroid for lung maturity. And of course, if patient starts bleeding before that, irrespective of the period of gestation, we have to do the emergency cesarean section and hysterectomy in some of the cases, or I would say in most of the cases. So, what is the preoperative preparation? Actually, general anesthesia is preferred because of the risk of profuse blood loss, and of sometimes the patients are hemodynamically unstable, which necessitates intubation. And of course, we do expect a prolonged surgery in these cases. And therefore, the large bore excess for the rapid transfusion, prophylactic antibiotics, pneumatic compression stockings pre-op, packed red blood cells, and FFP in the ratio of 1:1, at least 4 units of cross-matched blood should be available at the time of starting of the operation. But what happens in low resource setting? Very often, when we open for a routine cesarean section, like I discussed in one of the cases, she was previous 3 cesarean section undiagnosed, and placenta creta was diagnosed on table. So, what happens if on table it is undiagnosed? Then, how to suspect that it is placenta? It could be a placenta creta. You can see in this diagram the distended lower segment with placenta bulging almost up to the serosa. So there's a distorted lower segment, blood vessels in the serosa, placental invasion can be seen right up to the serosa or into the bladder or into the surrounding tissue. We know that it is placenta accreta. So another question is, if we on the table after opening we diagnose that okay, it is placenta accreta. Now the dilemma is whether to tackle it here or to transfer. So I would suggest, if the the operating doctor is not skilled enough in doing cesarean hysterectomy, and another is if no facility for ICU and blood products and to motivate or to mobilize a massive transfusion protocol, it is better to delay the uterine incision till the condition are optimized. Like, suppose a resident has opened it at night and she suddenly finds that it is a case of placenta accreta. Wait, do not. I always tell my resident, do not give uterine incision. Just wait for seniors to come. Senior obstetrician, senior anesthesiologist, mobilize. You inform your ICU setting, inform anesthesiologist, go to the blood bank, delay uterine incision till the condition or optimized. This is very, very important aspect in case of undiagnosed placenta, which is diagnosed on table. So, or otherwise, if you have opened in a center where no ICU facility, no facility to mobilize massive blood transfusion protocol, no senior obstetrician, it is advisable to close the abdomen and uh, without giving incision on the uterus and transfer to the higher tertiary center where a multidisciplinary team is available. Of course, after informing that center and proper arranging a proper transfer in ambulance with 2 IV line, with blood arrangements and everything. So these are the diagnostic and management dilemmas which we usually face in the low resource settings. So, but what happens sometimes? What happens when we are planning to sift, but patient starts bleeding heavily? So, we have to do emergency obstetric hysterectomy. How to go about it? The simple tips are: we can do aortic compression when the abdomen is opened, and meanwhile we pump in fluids, rush for blood, call for help And if you have to do cesarean hysterectomy, you plan your incision at the upper end of the placenta, either transverse or vertical, as I showed in my previous case scenarios. Deliver the baby. Do not separate the placenta. This is the most important tip. Do not separate the placenta because it will result in torrential hemorrhage. So close the uterine incision, give oxytocic, tranexamic acid, go on putting the clamp till the uterine. This is equivalent to devascularization, and do hysterectomy. Subtotal is a faster one, but if placenta is previa, then of course a total hysterectomy would be required. So the management approach of doing a peripartum or cesarean hysterectomy is the traditional approach for managing placenta acrita. It should be done as elective procedure, but at times it might, even in planned cases, we might have to do it on emergency basis. And of course, the uterine incision is to be performed away from the placental bed. A fetus is delivered, followed by hysterectomy. Do not attempt to separate the placenta from the uterine wall. This I'm going to emphasize again and again because that is going to cause massive obstetric hemorrhage. So advantage of not separating the placenta is that it reduces the bleeding. But sometimes what happens, the bleeding can continue after hysterectomy as abnormally adherent placenta receives blood supply from vessels arising from upper segment of the vagina. Torrential bleeding during hysterectomy can occur, and there is a high risk of damage to the adjacent organs such as bladder or ureter. So sometimes we usually are following cesarean hysterectomy at the time of as a management approach for placenta acrita, but there are conservative approaches like intentional retention of the placenta. But the prerequisite is hemodynamic stability, normal coagulation profile, uh, and the steps are same. That we incise the uterus at the upper placental border. Sorry for the mistake. It is not bladder, it is border. Clamp, cut, and ligate the umbilical cord very close to the placental surface. Leave the placenta in situ. Do not give oxytocin because it can stimulate bleeding from the partially unattached placenta. Close the uterine incision and do a good post-operative follow-up. But the disadvantage is that sometimes we have to wait for a longer period, maybe up to 20 weeks, for complete resolution of the placenta. We have to give prophylactic antibiotic. There is risk of secondary hemorrhage, sepsis, and sometimes the need for interval and emergency peripartum hysterectomy. Methotrexate is not recommended because methotrexate acts only on a rapidly dividing trophoblastic tissue, which is not happening in this case. So as a part of follow-up, we recommend to do a serial ultrasound and sometimes beta HCG gonadotropins. So another conservative approach is triple P procedure, where 3P stands for preoperative transabdominal ultrasound localization of the superior border of the placenta, pelvic devascularization by inflating pre-placed pelvic arterial occlusion balloon, and placental non-separation with myometrial excision and reconstruction of the uterine wall. So you can see this is the incision, a transverse incision with a board separate flap on the rectus sheath showing the upper margin of the placenta. So incision is given at the upper margin, baby is delivered, placenta is not touched, and you can see the placenta along with the myometrium has been resected and then it is closed. So after actually in this case, before the surgery, intra-arterial balloon catheterization is done, and these balloons are inflated for approximately 2 hours. And after 2 hours, the occlusive balloons are deflated, but intravascular catheters are removed only after 24 hours because at times, if bleeding recurs, embolization can be performed. And postnatal follow-up of these patients involves quantification of the beta HCG after the surgery and till 6 weeks postnatally because sometimes some of the placental tissue might be left behind, but by 6 weeks, most of the patients will have complete resorption of the placental tissue. Now, what is the modified triple P procedures? In resource setting hours, I do not have experience of doing this triple P procedures, but in one case we had done uh, uh, actually that the I mean, instead of the intra-arterial balloon catheterization, we did the bilateral uterine artery ligation, because a case of actually a placenta accreta in one of the conua. So we excised this conua and we desutured it. So instead of doing the intra-arterial balloon catheterization of the internal iliac artery, we did vascularization by doing a bilateral ligation of the uterine arteries. So that is helpful in low resource setting like ours. So another new surgical techniques are retrograde hysterectomy. Personally, we are doing the hysterectomy in a usual way, but literature have described retrograde hysterectomy. The advantages are that there's a significantly less blood loss. In this case, actually, the ligation of internal iliac or uterine or both is done before dissecting the bladder, and plane of cleavage between the bladder and uterus is developed more easily. Is there any role of embolization or urethric catheterization? Well, current evidences is insufficient to make a firm recommendation for the routine use of the balloon catheter or embolization. And similarly, RCOG does not recommend the routine use of the urethric stents. Uh, uh, this is I want to discuss this article of ours which was published in Journal of Cephog, and this was regarding our current practices in the management of placenta accreta spectrum and low resource setting. I was one of the authors, and actually the silent feature of this our study was basically the objective was to determine the prevailing practices for the management of PAS in India and to formulate a readily translatable practical management approach for the low resource setting. This was a cross-sectional study which was conducted from April 2019 to March 2020 across 9 tertiary centers in India. So what was the finding? Actually, 78 patients had PAS. The prevalence rate was 0.12%. Caesarean scarring was the most important risk factor. There were almost 43% of the women uh, unbooked. So this was a very important finding. Only about half of the women were booked cases and undergoing regular antenatal checkup. Ultrasound could diagnose PLAS in only 51.3% of the cases, and half of the cases were again undiagnosed. Caesarean hysterectomy and interval hysterectomy was taken in 84 and 8% women respectively. Intraoperative hemorrhage and neurological injury was the most common complication. So based on these findings, the algorithm which we suggested for low resource setting was something like this. If in antenatal clinic you should suspect placenta accreta spectrum on the basis of clinical risk factor which we discussed, and in these cases ultrasound should be done by a radiologist who has expertise in diagnosis of PAS, and if required MRI can be used. If there is no PAS, still we have to be very vigilant about, especially in cases of placenta previa, and we have to repeat the ultrasound at 28 weeks. When PAS is confirmed, we have to counsel the couple about for the delivery at tertiary center, and we have to refer the patient to tertiary center, of course, after correction of anemia. So empirical antenatal steroid should be given at 28 weeks, admission at 34 weeks or even earlier if bleeding occurs. Consent for cesarean hysterectomy should be taken, adequate availability of the blood should be there, planned elective surgery at 34 to 37 weeks, and surgery should be taken only by senior faculty. This is very, very important. And sometimes conservative procedure can also be looked for. It is not, especially in case of focal placenta adherenta or focal placenta accreta, we can think about conservative procedures. And these are the surgical procedure which we anticipate: classical cesarean, high vertical hysterotomy, and sometimes hemostatic sutures in the placental bed, internal iliac ligation, and sometimes even if we leave the placenta, intentional retention of the placenta is done in the post-operative period or in the puerperal period when she starts bleeding, we might have to do interval hysterectomy. So this was the algorithm which we proposed in our article. So with this, I would like to summarize with some key messages about my topic. Of course, with the increase in cesarean rate, PAS disorder have also increased and have become an important cause of maternal and fetal morbidity and mortality. Women in developing countries are more likely to die from PAS because of the lack of access to the prenatal diagnosis and intensive care facilities. Ultrasound with color Doppler is the diagnostic tool for PAS. However, pregnant women in low resource setting may not have access to the screening ultrasound, and placental location is not always done by a qualified, experienced radiologist. As I discussed in one of the case, even if the ultrasound was done, it was the placenta agrita was not mentioned, or not because it could not be diagnosed. So, because of these factors, placenta acuta syndromes are often diagnosed on table only during the intrapartum period. So, due to these reasons, the clinical and surgical risk factor evaluation during antenatal checkup is very important for risk stratification in low resource setting. It should always be suspected and anticipated in women with multiple cesarean or previous cesarean with previa. Availability of the ultrasound and necessary skill for detection of PAS are important factor for diagnosis and management of PAS. Therefore, both the radiologist and obstetrician should be adequately trained for this condition. And women with clinical risk factor actually should have an ultrasound by an experienced provider and should be counseled for delivery at the tertiary center with multidisciplinary team for management facilities and where facilities for massive blood transfusion is there. Timely referral to the tertiary center is important for reducing morbidity and mortality. Regardless of intraoperative diagnosis, emergency cesarean hysterectomy without attempt to remove the placenta by an experienced obstetrician with activation of the blood bank and anesthesia team, it helps in reducing morbidity and mortality. So, with this, I would like to end my talk. Thank you so much for patient. There's not a live audience, but so, of course, for being with me. And I would like to end with a quote by Sir William Osler: "To study the phenomena of disease without books is to sail an uncharted sea, but to study books without patient is not to go to sea at all." Thank you so much.
Thank you, Dr. Archana, for your presentation. So, anyone having any questions?
Thank you very much for the presentation. Do you mind telling how often do you scan the women where you leave the placenta in, and how long you keep them as an inpatient? Thank you.
Sorry, I mean you want to know if we leave behind the placenta during surgery, then how often we follow our patient? That is your question, right? Hello? Hello, yes, Bushra Jahid, you can ask your question again. You
Yes,
want to know
yes,
when?
that is my question.
Yes, if we leave behind the placenta, how frequently we do the ultrasound? Actually, I have the experience of leaving behind the placenta in one case, and this patient had an uneventful recovery in the post-operative period. We discharged the patient on seventh day, and we kept her calling. We did ultrasound because this was our first experience. We were more worried. We were doing ultrasound initially every month and but after 3 months, of course, he was kept inpatient only for 7 days. We discharged her after 7 days, but she was called for regular ultrasound for every month for up to 6 months. And although the uterine involution was very good, the placenta could not be we could not see the complete resorption of the placenta. We could still see the echogenic area within the uh, uterine cavity for almost 6 months. Although she did not have any bleeding, she developed amenorrhea, and she came for follow-up only for till 1 year. She was having amenorrhea, and she did not turn up again for follow-up. I mean, we lost her to follow-up. Yes, I think that answers your question.
Thank you very much. Yes.
Thank you for that question.
So, thank you. So, anyone else have any questions? Okay, no questions then. Thank you once again for your presence and presentation.
Thank you for giving me this opportunity.
Thank you. So
Do we,
our
do
next,
we have a
yes,
recording of our sessions?
I mean me.
I mean, whoever the organizers, are they recording our
Yes, yes,
presentation?
it is recording. Yes, we will upload in the YouTube and we'll give you the link.
Okay, that's fine.
Yes.
And when will we get the certificates of?
Certificates after the completion of 2 days program, we will
So that
send you the certificates. That
it
will
will be
be
a
on
soft.
16th. Yeah, that
It
will
will
be
be a
soft
soft
copy on
copy.
16th. Yes.
Okay, thank you.
Yes. Okay. Thank you. So our next presenter is Dr. Bushra Zahid Saeed from the Princess Alexandra Hospital NHS Trust, United Kingdom. And the title of the talk is A Snapshot of Emergency Caesarean Section at District General Hospital. So for Dr. Bushra, Ms. Esther will share the screen. I'm going to make you the presenter. Yes. Yes, you can make it a full screen.
Thank you very much.
Yes. No, it's not full screen. Yes, please start.
This
And
is
please let us know when we have to change the slide. She will do it.
perfect.
Okay.
Hello, everyone. I am Bushra Zahid Saeed. I'm Year 7 trainee in obstetrics and gynecology at East of England Deanery, and I'm based in Cambridge, UK. Thank you very much for giving me the opportunity to present my work here. A snapshot of emergency cesarean section at Princess Alexandra Hospital, NHS Trust, United Kingdom. So as you all know, according to WHO as well, cesarean section rate continue to rise globally. Currently, more than 1 in 5 of all childbirth, and it will continue to increase over the coming decades, with a third of births likely to take place by cesarean section by 2030. So we looked in our department, the rate, obviously we are not concentrating only on the rate of emergency cesarean section, but mainly to look into the indications why all these emergency cesarean sections were performed. We looked into the month of October 2021, and 70 patients had emergency cesarean section. 58 sets were randomly selected, and we reviewed all the notes, and the data was collected from maternity database using emergency cesarean section for the search. Next slide, please. Sorry, move two more methods. If you come to, so next slide, and move one more, please. Sorry, I forgot to tell you. Perfect, thank you. So we looked into the category of emergency cesarean section from 1 to 3, and indication of emergency cesarean section documented in the notes. Whether this was a spontaneous labor or was this woman had induction of labor. Was she on oxytocin, and were there any IV antibiotics given in this case? Use of CTG analysis sticker during the labor and a decision of emergency cesarean section. In our department, we are using the physiological CTG interpretation, and we have specific stickers which we use throughout the labor and at time of decision as well. Also, we looked at neonatal admission in these cases. Please move the slide. Thank you. So nearly more than 50% of the women had category 2 emergency cesarean section, followed by 22% needed category 3 cesarean section, and almost similar had category 1 cesarean section. Please move the slide. So there was a wide range of indication in these cases, and most common was suboptimal progress during labor, almost around 19% of cases, followed by suspected fetal compromise on CTG. That was the case in 15% of cases. Prolonged deceleration not recovering in 13% of cases. Undiagnosed breach in labor, unsuccessful induction of labor, booked elective cesarean section and presented in labor, these all around between 9 to 11%. Growth concern during antenatal period or unprovoked deceleration in 7% of cases. Chorioamnionitis, around 7% of cases. Tocophobia, placental abruption, cord prolapse, and severe preeclampsia, all of these are around 2% of cases. Thank you. Could you please move the slide? So CTG analysis sticker was used only in less than 50% of the cases, and 52% of patients, they were either used on few occasions or not used. Please move the slide. And at the time of decision to deliver with emergency cesarean section, only nearly 30% of women had the CTG analysis sticker in their notes. Next slide, please. Induction of labor versus spontaneous of labor. Almost similar number of women ended up in emergency cesarean section, and in 10% of cases, it was not applicable. Next slide, please. Thank you. 32% of cases had oxytocin in labor. In 15 cases, there was meconium, but that was not indication of cesarean. And IV antibiotics were used in 10% of the cases. 9% of the babies needed neonatal admission. Next slide, please. And the babies who needed admission, around 40% were the preterm babies. And the range for stay in the neonatal unit was from 1 day to 56 days. The baby who needed to stay for 56 days was born at 28 weeks of gestation, and indication was likely placental abruption, which was confirmed at time of cesarean section. This baby who needed to stay for 11 days, it was again a preterm baby born at 30 weeks, and it was preterm long rupture of membranes. 5 days baby needed to stay in was a previous 2 cesarean section. She came in established labor and had a category 2 emergency cesarean section. And 1 day stay for a baby, which was again placental abruption and needed resuscitation at time of delivery. So conclusion from our study was there were total 367 babies were born during month of October in 2021, and 70 of them needed emergency cesarean section delivery. Main reason or indication was suboptimal progress in labor or fetal distress on CTG. Majority of the women had either spinal anesthesia or top of their epidural. Only 10% needed general anesthetic, and these were category 1 cesarean sections. Emergency cesarean section rate for induction of women labor versus spontaneous labor was almost same, which is again confirmed as per NICE guidelines. Induction does not increase the risk of having a cesarean section. 10% of these women had a full dilatation section. So we recommended in our department the documentation is as very important, especially in the cases where we need to go back and look into them. So there should be a clear documentation. On each board round or any review during labor, we should be using our CTG analysis stickers, and especially at time of decision, and they need to write whether there's a hypoxia or there's any change on the CTG, and that is the reason for cesarean. Educational workshops that engages the women in childbirth and preparation, psychosocial supports or perinatal mental health team, the specialist midwives, they run these sessions for the women, like having tocophobia and requesting elective cesarean sections. Regular audits of indication of cesarean section for learning reasons to train our trainees. And as you may all have heard about BBC News, that NHS England drops the limit on offering cesarean birth. Previously, maternity units were encouraged to promote natural birth and keep the cesarean section rate to about 20%. After having few reports and investigations, the NICE guideline has been updated and maternity staff has been advised to treat the cases on individual basis and follow NICE guidance, allowing the women to opt out for a planned cesarean section, even if it is not a medical indication. Thank you very much, everyone, for your time. And any questions?
Thank you, Dr. Bushra, for your presentation. So
And
anyone
thank you,
having any
Health.
questions?
Yes, Dr. Bushra, that was a nice presentation, but I mean, your data was or basically it was you reviewed the cases who underwent an emergency cesarean section,
Yes.
right? So, what was the commonest indication for doing emergency cesarean?
So that was suboptimal progress in labor.
Suboptimal progress in labor, but how do you define that?
So as per the guidelines, if a woman is, once they are in labor, which means 4 centimeter dilated, having regular contractions, and every 4 hours expected to make at least 2 centimeter progress. If that is not happening, then we offer them oxytocin as long as CTG allows. So it depends of even after, like, let's say, giving them another 4 hours and reassess the situation.
So actually, you are not following the WHO recent labor care guide.
It's mainly the NICE guidelines which we follow here.
Okay. So do you have a system of allowing a birth companion?
Yes, we do.
Okay. And what is the second most common indication for doing emergency cesarean?
Suspected fetal compromise on CTG.
Fetal compromise in CTG. So, what was the mode of delivery of the baby? Like, how many of them did you categorize the emergency cesarean into first stage cesarean or second stage cesarean?
Yes, so 10% were second stage cesarean section.
So, second stage cesarean section, what was the mode of delivery of the baby? Was it a push method or pull method, or it was a soldier first method or Patwardhan method of delivery?
Majority of them was like as normal. The pet burner methods we don't normally practice in UK at the moment. So yes, either a cephalic as normal or breech extraction.
So, don't you find it difficult when the head is impacted into the lower uterines, into the
Absolutely,
vagina?
I agree. Second stage cesarean sections can be very challenging for the obstetrician. We do use
And especially for
fetal
the junior
pillow.
residents, like especially who are not less, not very much experienced.
Yes. So fetal pillow is something we have in our department which we can use, and that is a pillow we insert inside the vagina, and it's filled with the fluid and help to disimpact the
So,
head.
you don't, none of you practice Patwardhan method. Are you aware of that method?
Yes, absolutely. I had a teaching recently at Cambridge University Hospital, and they are running it's as a pilot program for impacted fetal head delivery during cesarean section, and they mentioned that in that, and only few of my Indian colleagues they were aware of, and I think one of them has practiced that in the past.
Yeah, actually, we are delivering most of the second stage cesarean section babies by
Hmm.
Patwardhan or soldier first. It is such a nice technique because in
Hmm.
what happened in second stage, lower segment is distended, friable,
Yeah,
and if you try to
absolutely.
introduce your hand to deliver the baby by cephalic,
Hmm.
actually being
Yeah.
a fragile lower segment, it often tears off. There's extension of the uterine incision,
Yeah.
very difficult to deliver the baby. But in
Yes.
Patwardhan technique, we are not introducing our hand into the lower segment. We are just
Hmm.
taking out the soldier first, delivering the
Shoulders
trach,
first. Yes.
the
Yeah.
baby,
Yeah. Yeah.
and lifting the baby to deliver the head. So it's such a beautiful
Yeah.
technique to deliver the second stage
Yeah.
impacted
Yeah.
head.
Yeah. The
So I
pilot
don't.
program has been started from Cambridge University. So hopefully, let's see if it we trained our staff, then we can practice that.
Okay, thank you so much.
You're most welcome.
So thank you, Dr. Bushra. Is anyone else have any questions? No questions. Thank you once again for your presence and presentation.
Thank you.
Thank you. So our next presenter is Dr. Maria Velena from Germany, and the title of the talk is Integrating the Embodiment Projection Role Paradigm to Develop and Implement a 2-hour workshop for stress management among nurses. Hello, Dr. Maria.
Hello, everyone. I hope that you can hear me well.
Yes, and you are
Brilliant,
the presenter now. Please share your screen with us.
of course.
Yes, it is visible.
That's really great.
Yeah,
Okay,
please
nice.
make it a full screen.
Okay,
Yes, perfect.
nice. Thank you very much for your kind invitation, and I'm really happy that I will present our research work and will share that with you. I am a psychologist and I'm working at the Leibniz Research Center for Human Factors and Working Environment here in Germany. And as you perfectly said, the title of the presentation is Integrating the Embodiment Projection Role Paradigm to Develop and Implement a 2-hour workshop for stress management among nurses. The rapid changes in healthcare systems due to the COVID crisis have posed a huge burden on nurses' health. Interaction is a component, it's a primary component of the nursing profession. This work aspect requires emotional control of nurses' own feelings, but also the emotions of their care recipients so as to ensure high quality services. However, interactive work may imply internal emotional demands, which can cause a high physiological and psychological load and lead to serious health problems and burnout. Actually, the aim of the project that I'm working on, the digital angel, is to strengthen the work of nurses through smart classes in clinical settings and providing them with real-time information about individual health status, so as to allow nurses to implement stress prevention techniques based on integrative approaches when that is needed. By integrative approaches, we mean that we use techniques based on technology combined with different therapeutic approaches that are more traditional. As soon as a nurse has been exposed to a difficult situation that functions as a stressor, a generalized reaction caused in the body, in nurse's body. First at the brain level by the activation of the sympathetic nervous system. After that, and through the secretion of stress-related hormones such as cortisol and cytokines, a generalized reaction is take place. This reaction can affect heart rate and actually increase our heart activity, can cause immune changes, and also can affect mood and affects in an attempt to reestablish body balance. Resilience is actually a process that helps balance during adversities and stressful situations. And actually, what we have to do is to stop physiological and psychological reactions. And this is possible through different coping strategies. Indeed, through the years, different preventive programs have successfully incorporated coping strategies such as mindfulness, meditation, and breath regulation. And the results are really hopeful and really beneficial for well-being. However, it is still less unknown the use of a therapeutic framework in a workshop for stress management so as to teach nurses new coping strategies, but in a joyful, so to say, and a enjoyable way. So our research study was based on the embodiment projection role paradigm, and it had the aim to develop a deliver a theory-driven workshop in nurses at the German University Hospital of the Oldenburg. We teach during this workshop different relaxation techniques, and for this purpose, we adopted a quasi-experimental pre-post design so as to measure our main outcomes. One of the main outcomes was the measurement of the emotional states. This was realized through the German version of the positive and negative affect schedule. This questionnaire includes 10 adjectives that measure the positive affect and also 10 emotional words that measure the negative affect. And the second main outcome was the self-reported stress. and we measured that through the visual analog scale. This scale has one ending, this is a 0, and means not at all stress, and can reach scores till 100, and this means the maximum stress that one can perceive. We measured our outcomes at different time points. This means before and after our workshop. And at the end, we requested our participants to evaluate the overall workshop. Participants had to work in positions related to service user care as nurses. It was not expected that our participant had the previous experience with the drama therapy or different relaxation techniques, but it was really important for us that our participants were motivated actually to participate vividly in different experiential activities. To recruit our participants, we used a convenient sampling method. So we reached our participants through informative emails, and we posted advertisements on the campus of the Pius Hospital Oldenburg in collaboration with the respective the responsive manager from the hosting organization. Actually, the University Hospital in the Oldenburg has different cultures and infrastructures, and actually that would help us maybe to select a heterogeneous sample, and maybe help us through this way to encourage transferability of our concept into different working settings. Finally, 9 participants took part in the workshop with the mean age 44 years. During the first part of our workshop, participants signed the consent form and the respective questionnaires, and took part in warm-up activities. These warm-up activities aimed to reduce tension and to learn participants themselves better, and also the other group members. It was really, really important to build trust for the following parts. The next stage of our workshop was related to the embodiment projection role paradigm. This paradigm derives from the drama therapy and has to do with the developmental stages of children. Actually, these stages are active throughout lifespan and can influence individuals in different stages. And for example, when individual gains with activities like hobbies or careers. So the embodiment has to do with the awareness of one's own body. And the respective exercise was relevant to sensory and physical mobilization. And the participants, for example, had to move around the room and to move different body parts so as to activate their physiology. And this was equal or similar to different situations, like the stress situation, where our body reacts and heart rate is increased. The second exercise was based on the projection. Actually, projection has to do with expressing our own emotions. And these participants had to paint a human body and actually to show where this human body might feel the stress. And through this process, maybe participants were able to realize the inner processes that take place through stressful situations. The last exercise was relevant to the role play, and this has to do with expressing and actually translating our emotion, perceive our emotions. The exercise was storytelling dramatization. And this exercise, during this role play, participants had to build a known story about an expert and a patient that was asking advice about stress and how he or she could deal with stress. This exercise is really helpful for the participants to process own feelings and difficult situations and actually to process and explain their own emotions. Furthermore, they can activate existing but also hidden knowledge about the coping strategies. The next stage of our program were the relaxation exercise. During this exercise, participants were presented a relaxation exercise based on breath regulation deriving from yoga nidra. That exercise was incorporated in mindful meditation deriving from cognitive behavioral therapy. And this exercise was the mindful meditation. In the first step, participants perceived their own breath, allowing them to concentrate consciously on it and decrease progressively their breath rate. As individuals voluntarily controlled their breath, they slowly transitioned, so to say, to an imagined scenery where they observed their thoughts and feelings in a non-evaluative way. This exercise was designed to enhance conscious awareness of moment-to-moment body-mind experience, including those of cognitive, sensory, and emotional nature. The reflection of one's current thoughts and feelings targets at promoting acceptance of the experiences rather than categorizing them as good or bad. During the last stage of our workshop, that was the reflection of participants' own feelings and thoughts. So the participants had the opportunity to discuss about the feelings and thoughts that that might have not the opportunity to do that so far before the end of the workshop. And also they completed different questionnaires supported for measuring our outcomes. For assessing our results and in particular the changes in self-reported stress and affect, we used paired samples t-tests based on SPSS software program, the version 28. In the next diagram, you can see the mean change with respect to group stress scores according to the visual analog scale. Actually, the recorded scores show statistically significant decrease of stress from baseline to post intervention, and this may show that our workshop was successful for managing stress among nurses. In the next slide, you can see the scores, the mean scores regarding group negative affect. And actually, our results indicate that the negative affect was improved from baseline to post-intervention, and this change was statistically significant. However, although our results indicated that maybe was a positive change regarding the positive affect, this result didn't achieve statistical significance. Lastly, our participants, as I said before, were requested to evaluate the overall group experience within the workshop. And actually, according to our results, the overall experience of the participants was very, very positive. The aim of our study was to integrate embodiment projection role paradigm, a therapeutic approach, so to say, into preventive program for stress management among nurses. This workshop indicated that nurses could modulate stress and negative affect after the end of the intervention. It seems that EPR program paradigm may be a promising and effective method for stress management programs. However, positive affect couldn't be improved. So special emphasis should be paid to enhancing positive affect, integrating and bracing techniques that are responsible for improving positive emotional states. These techniques can be related to interpersonal domain and also to social connectedness. This means that there is more room for improvement for our concept, and so further future studies could motivate fruitful research directions by embracing NPR, and actually they can explicitly focus on understanding the processes that are involved in changes for positive affect and negative affect, and also can focus on exploring the long-term effects of this concept as compared to well-established preventive programs. So I would say that a healthy staff is essential to high quality healthcare services and to preventing mental health problems at the workplace. So our priorities would be to improve health professionals' health, especially after COVID crisis, and focus on the era after it. I would like to thank you for your attention, and now the floor is yours for your questions. Thank you very much for your attention.
Thank you, Dr. Maria, for your presentation. So anyone having any questions? Okay, no questions. Thank you once again for your presence and presentation.
You're welcome.
So,
Thank you very much.
thank you. So, as our the presenter, Miss Dr. Nabinita, has not yet joined, so please allow me a few moments so that I will contact. Where is she? So hello. We tried to contact Dr. Navnita, but she's unreachable. So we will schedule her talk tomorrow. So thank you one and all. So by this we came to end of our all talks for today webinar, day 1. So we will close the program for today and we'll continue with tomorrow. Thank you everyone for making it successful and have a nice day.